Okay.
Good evening, everyone. Okay. This is the January 21st meeting of the Quality of Life Committee. I am Mariana James, Pat Moore's co-chair, Pat Moore, Zach, our district manager, and these are our members. We are going to begin tonight with the presentation on the New York Health Act with Bill Ferns, Senior Advocate Leadership Team, that is SALT. Also, Melanie D. Arriga, I don't know if I'm pronouncing that
I
correctly.
think she's actually online.
She might be online. Executive Director for the Campaign for New York Health. Then we have
Richard Godfrey.
Assemblyman
Right.
Richard Godfrey, yes. Anyone else?
And Ann Litlander.
And- Nice to meet you.
So, yeah.
Okay, you guys feel free to get started.
We just weren't sure, we don't want to go too long, so how long should we plan on?
How long do you need? Just go.
My wife says, says when I talk, it's Ferns-plaining. So I
It's
can go
okay.
on forever, so I'm just gonna be quick. My name is Bill Ferns. I'm involved in a group called the Senior Advocacy Leadership Team. We work out of the Manny Cantor Center over on the Lower East Side. We're a pretty hyper-local group generally, dealing with things like getting better bus service. We actually campaigned to get elevators at the Delancey Essex stop because there was no subway stations in the Lower East Side that had elevators. It's now on the 5-year plan with the MTA, things like that. So generally, we don't take on big issue, things like this. But this bill is important a lot to seniors because especially in the areas of the long-term care, it will solve a lot of the concerns people have about spend down issues that happen with Medicaid. It turns out, if you think about the generation that started to be able to accumulate generational wealth when the Civil Rights Bill was passed and when the immigration bills were changed, they are now at the people who are ready to pass on that generational wealth, but they're afraid of having to spend it down. So it's a concern with us, and this is pretty much like a nonpartisan issue. So, we're really behind it. The main idea is that there will be New York State will be a single payer insurance system, not a single provider. So people try to compare it to like the English national health system. That's a single provider. No, there'd be a single payer. There'd still be all those great providers we have in New York City. But it would squeeze out a lot of the profit that private insurance companies have. It will squeeze out a lot of the administrative costs that the providers have because they have to deal with dozens of insurance companies, and it will cover more people. Now, Dick will talk much more about the details, so I'm going to just leave it up to him. I had sent Mariama, but I only sent it today. I thought I sent it previously, but I found it in my draft file as a draft.
We printed it.
Oh, okay. Now, that's just a draft. I just wanted to make it easy for the committee to draw whatever they wanted. She has the Word file, but I think you'll get the idea of where we're at. So I think I'm gonna give the floor to Richard. Thank you. Oh, Ann's gonna go first? Okay, leave the floor to Ann. So.
The same, it's the same thing.
Hi, thank you for having us here tonight.
Do this.
So my name is Ann Litlander. I'm a longtime Lower East Sider. And a product of New York City Public Schools, City University and State University. So that health and life in New York is a big concern to me. I recently retired after being a primary care doctor, mainly at federally qualified health centers for close to 40 years. And this issue is just very dear to my heart. Because in that time, I've seen over and over again, the human tragedy that occurs for uninsured or underinsured. I had patients who couldn't afford the copays on their medication or the copays required by their insurance to see a specialist. And at the very end of my tenure, copays to see me. I spent hours on the phone trying to get approval for a crucial test or medication for a patient after their insurance company had turned them down. And now as a retiree and on Medicare myself, I'm worried for me and I'm worried for my peers. A few weeks ago, I was online in the Duane Reade on Delancey and Ludlow Street behind a woman whose insurance had lapsed and who had run out of her high blood pressure medication a few weeks ago. And she talked to the pharmacist about how bad she was feeling and the headache that she had and that she had not had any of her medication. And she was told that by the pharmacist or the clerk that her insurance was no longer active. And she said, well, how much would it cost me if I just bought it out of pocket? And they said $176. So she left without it. And this is someone who will be at high risk for developing kidney failure, heart attack, or a stroke. And it's not a unique situation. There are over 1 million New Yorkers who have no health insurance, and that number is bound to go up with the federal cutbacks to New York, including $7.5 billion loss of federal funding to New York State by the federal government for health care. The average monthly cost of health insurance through the Affordable Care Act has just increased because Congress failed to pass the tax exemptions that the Democrats had walked out over. Many families are opting now not to have any health insurance because of these increases, and people are being forced to make choices between buying health insurance for their family or food for their family or clothes for their kids when they go back to school. People who are covered through their employers have seen a huge rise in employee contributions and in the size of the deductibles and the co-pays. Hospitals in New York State, particularly in rural areas, are at risk of closing because of the amount of funding that they will have to forfeit or that they will lose when they are treating indigent patients who do not have insurance. And although residents of Community Board 1 have actually a higher rate of being insured and a lower rate of chronic illness than for the rest of the city, this is going to present a crisis for everyone in New York. As fewer people are insured, fewer will have access to primary care, fewer will have access to their medication. So the lady in the drugstore will eventually end up in the emergency room with a severe headache. She'll need ER level care. She'll need a CAT scan or an MRI. She may need a hospitalization. She may need a cardiac catheterization. That's a lot more expensive than if she got her blood pressure medications. An uninsured child will end up in the emergency room with an ear infection, now complicated by not having had primary care attention on time or got medications early in the infection. And the otherwise healthy driver from Battery Park City who's running and trips and breaks his ankle is going to have to wait hours and hours and hours in the emergency room because it's going to be full of people who could have had their needs taken care of in a primary care setting had they been insured. So this is not just going to affect those of us who are on fixed incomes. It's not just going to affect those of us whose health insurance has just gone up. It's going to affect all of us in all of our communities. So as Bill talked about, the New York Health Act will create a single payer system in New York for all New Yorkers and for anyone who works in New York City. And that will eliminate private for-profit insurance companies. It will be more efficient because billing will be done to a single payer. It will be funded through the state through a progressive payroll tax and employer and employee contributions for those workers who are covered in their workplace. It will amount to less than many families and employers are paying now. And here are some other advantages to it. Everyone who lives and works in New York State will be covered, regardless of age, pre-existing conditions, or immigration status. Coverage will include primary and specialty care, dental, vision, mental health, pharmacy, and most important for our seniors, long-term care. There will be no copays, deductibles, or networks. There will be no need for prior authorization. And we expect that prescription costs are gonna be lower because the state, as the sole payer, will have tremendous negotiating power with the pharmaceutical industry. And there will be an elimination of bureaucracy. I was always amazed at the community health center where I worked and how many people it took to bill. And we still didn't do it very well because everyone who came in was probably covered by 2, possibly 3 different types of insurance, each of which paid for something. People's insurance changed every year. It creates a tremendous bureaucracy, both for the insurance companies, which they charge consumers for, and on the part of community health centers and hospitals, which raise the price of patient care. So I'm really hoping that this will pass this year. I think given the situation in Washington, it's more urgent than ever to make sure that all New Yorkers are covered. It won't be a perfect system, but we'll learn as we go. And I'm gonna turn it over to Assemblyman Godfrey to go through some of the more details and to open it up for questions.
Okay. Okay, what's wrong with shit?
That's fine. Make yourself at home.
So, while the federal cuts have made almost everything about healthcare worse, almost everything I'm gonna say this evening, I wrote down, before Donald Trump's second term. It's primarily about what's wrong and been wrong with our healthcare system, the way we pay for it, for years. Every year, about a third of households that have health coverage, I'm not talking about the uninsured, about a third of households that have health coverage have someone in the household who goes without care for needed care for financial reasons or suffers financial hardship, to pay for it. And in a sense, everyone in New York is underinsured. And that's because of all of the money that we have to pay for premiums and deductibles and copays, that are not at all based on ability to pay. The insurance company wants the same premium or deductible, whether you're a multi-million a year executive or the receptionist. Our coverage has, restricted provider networks and restricted drug formularies. If you go to a doctor that isn't in the insurance company's network, you're gonna pay more. If your doctor prescribes a drug that isn't on the insurance company's formulary, you're gonna pay an arm and a leg for it. Insurance companies, feel free and do constantly, deny coverage for the care, that your doctor has recommended. And either your doctor has to spend a lot of time arguing with the insurance company, and hopefully prevailing, or you go without the care, or you pay an enormous amount out of pocket. And of course, almost none of us have any kind of coverage, that covers long-term, home care or nursing home care, unless you spend down, to the Medicaid poverty level, or you have very substantial life savings and wipe out a big chunk of them, to pay for long-term care or for long-term care, coverage. And without it, if you're not wiping out savings, chances are some member of the family, is giving up, her career, to care for an ailing or disabled, family member. We waste tens of billions of dollars a year just in New York State on insurance company bureaucracy, marketing, profit, and executive salaries. Doctors and hospitals and other providers spend an excessive amount of time and money fighting with insurance companies. We're the only, industrial democracy on the planet where that's the case. We pay the highest drug prices on the planet because nobody in our healthcare system, one health insurance company has enough bargaining clout to force down drug prices. There is an alternative. It's the New York Health Act, which would cover every resident of New York without regard to their income level or age or immigration status, et cetera. It provides complete benefits, doctor visits, hospitalization, dental, hearing, vision, long-term home care, long-term nursing home care, et cetera, et cetera. People at presentations like this often say to me, will it cover X? And, I'll ask, well, does your insurance now cover X, or do you know of insurance that covers X? And if their answer is yes, I have never had to say, oh, sorry, the New York Health Act won't cover it. We cover everything that any public or private health plan today covers, with no restricted provider network, no restricted drug formulary, no prior authorization for healthcare, and no premiums, deductibles, copays, certainly no out-of-network charges, because there will be no such thing as out-of-network. And it's paid for fairly through a progressively graduated tax, namely, based on ability to pay. Lower income pays a lower rate of tax than wealthier people. There would be a tax on what economists call earned income, basically payroll. The employer would have to pay at least 80% of the workers' New York Health Act payroll tax. They could pay more than that, particularly through collective bargaining. It would also apply to non-employment income if it is subject to the New York State income tax, like dividends and capital gains. The first $25,000 of any person's income would be at a zero rate, exempt from the tax. And if you're on Medicare, the first $50,000 a year of your income would be exempt from the tax, basically in recognition of all the federal money that you bring into the New York healthcare system by being on Medicare. Almost every New Yorker, 90 to 95% of New Yorkers, and there are any number of studies that document this, will spend less on New York Health Act taxes than we now spend on health care and health coverage. Now, you've got to ask, how can that be? This sounds too good to be true. How can you cover so much more and it's going to cost almost everybody less? Well, the key is the savings. We would save about $60 billion a year in New York by not spending over $26 billion a year on insurance company bureaucracy, marketing, profit, and executive salaries, because insurance companies would be out of the picture. We would save almost $20 billion a year by providers not having to put time and money, as much time and money into administrative costs. And we would save about $13 billion a year by bringing down prescription drug prices. Now, there would be increased spending, about $41 billion a year, because New York Health would be picking up out-of-pocket costs. We would be covering the roughly 1 million New Yorkers who are uninsured. We would be paying to fill the gaps in Medicare and Medicaid. We would be paying providers more than Medicare and Medicaid pay, because everyone knows that Medicare and Medicaid do not cover the full cost of providing care. And so New York Health would pay on top of what Medicare and Medicaid pay. And of course, it would cover long-term care. So that's about 41 billion in increased, spending that the program would be picking up. 60 billion minus about 41 billion, is savings of about $20 billion a year. That's how it is not too good to be true that almost all New Yorkers will be spending less under the New York Health Act than they now spend on coverage and care. You know, we're facing these federal cuts. The New York Health Act will not only fill the gaps in the current system, but will fill these new gaps because there will be more people uninsured, et cetera, et cetera. New York Health will fill those gaps, and it will do so basically using a portion of the annual billions in savings that the New York Health Act will generate. So without the New York Health Act, we will either let those new holes in the healthcare system sit there and say, oh, isn't that too bad? People are going to get sick and die. Or the state will try to fill those gaps, taking money from some other program like school aid or paving the state throughway. Or we will have to impose new taxes on New Yorkers on top of what New Yorkers are already spending. In other words, we will be paying for healthcare, not paying insurance corporations. Now, some people say, oh, you know, so many government plans really aren't all that good. Is the New York Health Act going to be good? How do we know that? And the basic answer is that the governor, every member of the legislature, their families, their friends, their wealthy campaign contributors will all be covered by the New York Health Act. And so they will have a powerful vested interest in making sure that it is as good a plan for them and for their doctors and hospitals as can possibly be. And 20 million of the rest of us get to ride along on that plan. Some people say, well, if it's going to be that good, why not? Why does it have to cover everyone? Why not make it a, what they sometimes call a public option? And the answer is that if it's not universal, you don't get most of the savings that you get by having it as a universal health coverage. And if some people are in the plan and some are not, you undermine the whole all in the same boat phenomenon that helps to guarantee the quality of the program. You know, for organized labor, healthcare should not have to be bargained for. And any union leader will tell you, as many of them tell me, every time they're at the bargaining table, they are under pressure to either sacrifice the health plan or sacrifice wages and other benefits. Under the New York Health Act, that will never have to happen again. And the New York Health Act's list of benefits is better than any employment or union health plan in existence. Now, some people say, well, gee, wouldn't it be better if it was a national plan? Why are we doing this here in New York State? Well, it'd be great if the federal government would do that. You know, it would be, you know, right now I compare it to looking for a federal plan, like buying a lottery ticket for a trip to Bermuda, but you have to go by train. You know, we're just not going to get there with a national health plan, you know, except for a couple of years in the 1960s and a few years in the 1930s. New York's politics has always been more progressive, more consumer friendly, more worker friendly than anything at the national level. And that's why New York has historically been the leader in a whole lot of issues, whether it's establishing free public education, which we did in the 1780s, or abolishing slavery, which we did in 1827, or enacting labor laws, health and safety regulations to protect workers, which we did in the 1910s and 20s and 30s. Our civil rights laws were state laws here in New York long before federal civil rights legislation. And if New York State goes ahead, believe me, other states will follow. I would bet that in a few years, the federal government will figure out that this is something that they should be chipping in to help pay for. You know, the child health insurance plan that we have started out with Minnesota enacting it in 1989. A year later, I always say I was happy to be part of a profession where plagiarism was not frowned on. A year later, we shamelessly copied Minnesota's law in New York and created Child Health Plus. That was in 1990. By the late 1990s, under President Clinton, the federal government said, oh, you know, any state that does anything like Minnesota and New York did for child health, we'll pay 2/3 of the money. And within a couple of years, every state in the union had adopted a child health plan, much like New York's, with federal funding. You know, Medicare and Medicaid have always allowed states to fill the gaps in those programs. You know, I'm a retired state employee, retired legislator. Thanks to all of your state taxes, I have very nice health coverage on top of my Medicare. So if I go to the doctor and the bill is, I don't know, make up a number, $500, Medicare will pay that. The doctor wants a lot more than 500. My state employee coverage will pay a few hundred on top of that. And then I pay a $25 deductible. Now, we didn't have to get the federal government's permission for New York to pay money on top of what Medicare pays. I didn't even know if the federal government knows that New York is doing that, but we do it. Medicaid, from the day Medicaid opened its doors in 1970, New York covered populations for which we do not get or did not get federal matching money, like childless adults. And since the federal government stopped allowing Medicaid money to pay for abortions, New York pays for it for people on Medicaid using state dollars. So there's a long tradition here for a mechanism like the New York Health Act. Now, the New York Health Act can work as a wraparound, as I've just described it, where we would pay on top of what Medicare and Medicaid pay and pick up what insurance companies used to cover. Now, if the federal government was smart and wanted to help save money, the federal government would give New York the money that it now spends in New York on Medicare and Medicaid. And that would all be put into one bank account with the state funds for the New York Health Act. And it would be a true single payer system, covering everything that Medicare and Medicaid now covers, you know, plus a lot more. So it could either be done as a wraparound to provide universal coverage for everyone, or it could be done as a true single payer system. That's basically my pitch. If you want to jot down my email address and if you want more information, it's Richard Gottfried, RICHARD, GOTT as in Thomas, F as in Frank, RIED @gmail.com. 2 T's, Richard Gottfried @gmail.com. If you've got questions that we don't answer tonight, write to me and I'll get back to you.
Okay, I have some for tonight, and I'm sure everybody else will.
One more time, GOTTFRI.
You know, I can send it to Mariana. And then she
Yeah.
send it to everyone, this, for the rest of the committee too.
At Gmail. Thank you.
So I have a couple of questions. Is there a possibility of doctors not wanting to participate in this, like for fear of not being paid on time or not being paid enough?
Yeah, the New York Health Act does not prohibit a doctor saying, I'm just gonna bill you directly and, you know, forget about the New York Health Act. There are very few New Yorkers who are wealthy enough to get their health care on that kind of basis. You know, there's a reason why we call rich people the 1%. But a doctor could do that. That doctor would have to be making his or her living off a very tiny slice of the population. They'd be a lot better off, getting paid by the New York Health Act. A few things about the way doctors would be paid and hospitals. You know, our family doctor, for the years before my wife and I were on Medicare, our family doctor refused to accept any insurance, because it was a pain in the neck. And so we would go to the doctor, we'd write him a check, and then we had to go to our health coverage and try to get money out of them. The one health plan that our family doctor has always accepted and does so today, and we're very happy about that, is traditional Medicare. That's the one set of insurance that he accepts. And if you ask him why, he says, I send them a bill, they send me a check. Nobody else does that.
So the New
And-
York Health Act would be administered by the same people who administer the Medicare,
Who are administering,
the same agency that administers the Medicare payments?
well, not Medicare, because that's federal, unless the federal
Well,
government hands us the money. It would be a state operation similar to Medicaid. And
That's different though from Medicaid. So that's what I'm getting at. With the
Yeah.
Medicaid, the payments can sometimes be slow.
Medicaid is, apart from the fact that its payment levels are too low, and the New York Health Act guarantees that its payment levels, even for people on Medicaid, will be higher than
Okay.
what Medicaid pays. Medicaid, other than that, is a reasonably efficient, payer. Even though they operate at about 3% administrative costs, and insurance companies operate at about a 20 or 30% administrative cost. And, you know, I've been involved in health policy for about 40 years. I have never met a practicing physician or a hospital executive who has a decent word to say about any insurance company. All right?
Yeah, so I don't disagree. I just get to that
Okay.
question because of my second question.
Well,
And
by the
maybe I
way,
should ask this one first.
The rate
lot-
of, let me just say, the rate of payment, you know, the bill, of course, doesn't say an appendicitis, you know, will be reimbursed at such and such a level. If we did, if that was in the bill, it would be several thousand pages long, and you'd have to amend it about every week. No, the bill has standards for how the New York Health Act will determine its payment levels. That language was written, we had a sit down with the medical society, folks that, as you might imagine, are pretty focused on making sure doctors are well paid.
Mhm.
They sat down with us and helped us write that language that's in the bill. And so, you know, they will never have to worry about a patient who doesn't pay their bill or doesn't have health coverage. There will be no more unpaid bills. They will never have to spend a lot of their time, as they do today, fighting with insurance companies. Doctor's gonna dance in the street.
Well, that question came to mind because Community Board One's district is home to a number of 9/11 survivors. And those 9/11 survivors would be treated by the World Trade Center Health Program. The World Trade Center Health Program first requires your insurance to pay and then pays the difference. We have highly specialized doctors that are then trained additionally to specifically treat World Trade Center disaster-related diseases. These doctors do not want to wait forever to get paid, and they're not going to take pennies. And so we would have difficulty retaining the level of expertise that's required for the World Trade Center Health Program if people can't be paid on it. So that's where that question came from.
Okay. Is the World Trade Center program,
That's federal. But it pays, like I said, secondary. So we would have.
okay, under the New York Health Act, the New York Health Program will cover all of that care. Now, I imagine we will continue to draw down federal money, but nobody, no doctor, no patient will have to first go to an insurance company to hopefully get them to pay a little. The New York Health Act will be there from minute one.
But we would need them to be paid timely and the right amount is what my only concern.
Yeah,
Yeah,
and
we're gonna answer to
and
our
that's the-
constituents.
And that's, again, the best guarantee of that is the all in the same boat phenomenon.
Mhm.
The governor and the members of the legislature and their families and their friends are not gonna want their doctors getting jerked around. They will make sure that their doctors are taken care of very well by the New York health system. And you and I get to ride along on the same program.
Okay.
Miriam, can I just also?
Of course.
Concretely, I know that the New York State Nurses Association is behind the Healthcare Act, the Doctors Council, the SEIU.
Mhm.
I looked up American Academy of Pediatrics, and I know that there's also a group called, was it Physicians for National
Oh, so,
Health
yeah.
Plan,
yeah.
the New York. So, we know that
If I thought about it prior, I could have invited Dr. Joan Reidman, like the former head of the World Trade Health Program, to be here with us, so she could, ensure that everything would be covered. But maybe I'll follow up with you guys and her, and try to make a
I think
connection.
the idea is the bill gets passed, and then there's the real sort of development of how it's gonna work. I mean, the bill's gonna be however many hundred lines long, but it's not gonna be the implementation plan. That's
Well,
gonna
there will be, there will be a whole lot of regulations that have to get written, complying with with the bill. There will be, a stack of payment rates for appendectomies and broken arms and lung cancer, whether caused by the World Trade Center or otherwise, of course. Just like an insurance company would have a big book like that. The difference is that that book will be written by people who are accountable to you and me, and not by a group of people who are accountable to an insurance corporation's stockholders.
Okay. What do we say to the unions that might suggest that this would have impact their ability to collective bargain?
Well, I guess you could say that back in the 1780s, when we created free public schools, we took away the ability of today's unions to collectively bargain, to have employers pay to send their workers' kids to elementary and high school. They don't have that collective bargaining right anymore. They never did, right? And that would be absurd if someone were to suggest that instead of publicly funded public schools, we should rely on unions to negotiate with employers so that our kids could learn arithmetic. I believe that healthcare is a human right, and it is not something that a union should have to bargain for. And like all the union leaders who have told me over the years, that every time they're at the bargaining table, either the health plan suffers or other wages and benefits suffer. And I imagine there are a lot of people in this room tonight who are familiar with the shenanigans that have been going on with New York City workers and retirees' health
Yes,
benefits.
yes.
I don't think New York City workers and retirees are being well served in that process. Under the New York Health Act, because New York City now pays 100% of the premium, there is specific language in the bill that guarantees that New York City will continue to pay 100% of New York City employees' payroll tax. And it guarantees, even though that was in the bill from the start, that the things that it covered were more inclusive than city health plan benefits, but it guarantees no restricted provider network, no restricted drug formulary, no deductible, no copay, no out-of-network charges, covering long-term care, no public employee health plan covers long-term care. I know that because my mother was a retired, New York City school teacher. Wiped out her home care, wiped out half her lifetime savings. Uh, and the bill has language that says, in case we've missed something, if there is any state or local public employer anywhere in the state, some tiny little school district in the Adirondacks that covers something that isn't already covered by the New York Health Act, it will automatically be covered by New York Health for all 20 million New Yorkers. So, yeah, the leaders of the municipal employee unions are opposed to the bill. I don't think they're speaking for their rank and file members. There are a lot of people who think they enjoy running for reelection by being seen as the one who delivers health coverage to their members. If the New York Health Act passes, they'll have to get reelected delivering wages and other benefits.
Can I just interject a couple concrete things? There's a lot of theory that, the Speaker of the Assembly has been pushing this, the unions are opposed. There's actually quite a few unions who were for it, 1199 is for it. Again, the state, what's the name of it? The New York State Nurses Association for it. They are, CWA, Communication Workers of America for it. UAW's for it. So,
32,
again, those of us
32
who.
BJ,
if
They
that-
had formally endorsed it?
yes, Bill Wholesale Department Store Union.
So those of us who are New York City retirees, as Richard pointed out, know that the Municipal Labor Council does not always act on the best interests of its members.
Okay.
And that includes the UFT, the DC 37, and we know the UFT is sort of changing its position in this like it did on the Medicare Advantage because of pressure from its members. So the idea that when opponents or people who are nervous about the bill say the unions are opposed to it, it's really not that many. It's a couple unions. It's a little bit of a canard.
I just wanted to say there was something positive that I didn't hear you mention, is that this would essentially be preventative medicine. So you would be saving money because people would, be able to go to the doctors as well as get their medications, so that you wouldn't be paying all this money we pay for people who get sick because they can't go to the doctor.
Yeah.
So that's another positive.
And
And that becomes an even more of an issue now with the question of what vaccines will be covered, because the insurance companies have traditionally said that they will only pay for vaccines that are in the official recommendations, which is gonna leave a lot of people in need of vaccines that will have coverage.
And now there's nothing.
They're not gonna pay for it, which is
Right, and so that's another reason I think in New York, we want to protect ourselves, we want to protect our families. We have to really make sure that we have something like this that will cover all of us.
Morgan, if you talk to doctors who do family medicine or pediatrics, basically primary care, which is where you get your preventive care primarily, they will tell you that they are, and always have been, very underpaid by private insurance. And one profound reason for that is that an insurance company knows that if you get good preventive care, you will in the long run be healthier and somebody will spend less on your health care. But the insurance company also knows that if they spend a lot of money on your preventive care today, 10 years from now, when you are healthier as a result, chances are you will have changed jobs and you'll be covered by some other insurance company. And that other insurance company will benefit from you being healthier and lower cost. And your first insurance company is gonna say, well, wait a minute, we paid to make her healthier. How come this other insurance company is getting the benefit? If you've got universal coverage, you don't have to worry about that.
Morning?
Yeah.
Then you, Diane.
Yeah, I have
if I could, just a couple of questions. When I was up in Albany, when I was on the state committee, Democratic committee, and we were discussing.
More, can you speak up?
Oh, we were discussing the Health Act, and I was under the impression that a lot of the unions were opposed because they felt that they had negotiated better coverage under their collective bargaining agreements than the New York Health Act would offer. Is that?
Yeah, and Donald Trump thinks we own Greenland already. It's just wrong.
One of the examples is what's going on with the nurses strike right now.
Yeah.
Which is that they may have good coverage, but it's one of the things that the hospitals are stalling on right now. In the negotiations, they are trying to pull back the amount of help.
And again,
So the fact that it might be better coverage now doesn't mean it's gonna stay that way.
and it's not better coverage. I have,
It's even better.
I've been involved with this bill, I'm not sponsoring it anymore, for about, 35, 36 years. I have never, ever had anyone come to me and say, you know, my union health plan covers X. Does the New York Health Act cover X? Every time I'm asked that question, the answer is of course. And for the public employees, because it's the public employee unions that are against the bill. A lot of the private sector unions strongly support it. For the public sector unions, we were able to put in language that says, as I said earlier, if there is any public employer, state or local, anywhere in the state that covers something that isn't already covered by the language of the New York Health Act, and there is no such thing, but if you could find one, it would be incorporated into the New York Health Act for all 20 million New Yorkers. And I have said that numerous times to numerous public employee union leaders. They keep saying, well, how do we know the benefits will be as good? It's spelled out in the bill.
And well, as you know,
And
that's.
by the way, there is no law that prevents public employee health benefits from being shredded. In New York City, employees are to some extent seeing that today.
Well, as you know,
Question?
when the state committee took a vote on a resolution in the act, it was defeated because of the objection of the public employee union. That was a couple of years ago. But anyway, that's neither here nor there. That's to make an argument in the future, which I may be in a position to respond to. But then the other question I have is if a are the private providers, private insurance providers still going to be in existence, like Health First, Fidelis, all those people? And are they still going to be insuring people through the marketplace if this Health Act provides, or will the marketplace be, in New York, be a thing of the past? Like the Obamacare,
No insurance companies
Yeah,
working in New York State. They'll exist in other states.
other state?
But if this is one, the insurance company will be New York State.
What happens if you're out of state and you're injured or get sick?
the New York Health Act has very specific language about that. And I'll give you a few examples. If you live in the northeast corner of Dutchess County, just up the road from Connecticut, and I always think of that because my parents used to have a house there. Everybody in town went to a doctor in Connecticut. And the local hospital that everybody went to was down the road in Connecticut. So the New York Health Act says if there are clinical reasons for you to go out of state, like that's where your doctor is, the New York Health Act will pay your out of state doctor. If you're hiking in the Grand Canyon and break your leg, and go to the emergency room, the New York Health Act will pay for it. If you live in Jamestown, New York, right next to Ohio, and you need fancy surgery, you're probably going to the Cleveland Clinic, not schlepping all the way to Albany Medical Center. The New York Health Act has language that says we'll pay for it. As long as if you're a resident of New York, even if you're temporarily out of state, New York Health Act will cover it.
You just
Diane,
answered my question.
Somebody
Yeah.
else has a question.
And I just want to also tell you that, the basic resolution has passed Community Board 3 at a vote of 34 for, 2 against, and 2 abstaining.
Yeah.
I can send you the vote sheet if you want it, but
No, I believe it did,
Okay.
you know, yeah, I believe you. We're asking these like, it's like a nuanced question because our district is a little different,
oh yeah,
you know.
But they're good questions, and they're questions that, a lot of people ask.
So if you're out of state and you're a New York
That's a
resident,
good question.
I just wanted to call the question to wrap it up.
We're gonna do.
Oh, okay, we're gonna wrap it up at 8:10.
Diane.
I'm
No,
sorry.
no, it's not, yeah, my question. What was your? She asked, it was what Miriam.
Good question.
Thank you. I want to say I'm in favor of this, but I have a question about what stops people, docs from doing concierge? 19% of families in New York do not use public school.
When
And
they
I would
say
imagine-
louder, can't understand.
So 19% of families in New York don't use public school, right? So I'm wondering, my doctors have gone concierge, what's gonna stop them from being the equivalent of a private school? And now all your doctors are gonna be concierge. I'm sure everybody here has had their doctor say, you know, I'm just gonna be out of pocket, right? What's to stop that happening from a lot of doctors? I mean, I know you said 1%, but 19% of families don't even use our public schools.
I
Yeah.
think complex question, I'll try to speak to a little bit of it and then have the assemblyman to answer the question. One is, I think we really need to keep in mind, there's very little private medicine left in New York City and in the United States. Most doctors are members of faculty practices and are salaried at this point. So I think that becomes less of an issue. I think the reason doctors go concierge is the reimbursement rate is low and the bureaucracy and the time to payment is very high. With a single payer system that will get better.
And also they wanna spend more time with their patients. My doctor's gone concierge, and when I go see, I pay him out of pocket and spends an hour and a half with me, as opposed to 7 minutes, which most doctors are
I
doing.
am not sure how many people can really swing concierge doctor. I mean, I know we said,
Sometimes you go to our family doctor.
isn't it a market? There's only so many people who can afford to pay for concierge, so what happens to all those concierge doctors who don't have enough patients, right? They got, I mean,
But I mean, if this passed, then, and, you know, and obviously, if the rates were high enough, doctors would stop being concierge doctors and still be able to spend quality time with their patients.
Yeah.
And get a fair payment for their time.
A follow on for that is the utilization rates of doctors. If there's no gatekeeping on suddenly, the reason that I'm asking this question, I was just on jury duty, and I was eavesdropping to some people who just got covered in healthcare. And the girl's like, oh, I just got this fantastic healthcare. I went to every doctor I could go to. And I know that happens, right? So now there's gonna be no gatekeeping. So the utilization rate is gonna go way up. How does the New York City, and I don't know this answer, doctors, do we have enough doctors for all this utilization that suddenly people are gonna, I mean, I would go to a lot of specialists, right?
Well, you know, with only a little bit of tongue in cheek, you could say that, you know, who has time to spend half their day going to the doctor? And part of the answer to that is people who are already covered by Medicare. And so, right, they already have the coverage that enables them to spend half a day at the doctor.
Retirees.
The other piece of it, I think, is that concierge medicine is not going to ever cover all of everybody's health needs. It's a solution for some people for primary care services and maybe some of the other office-based specialties. But you cannot have a surgical practice that is concierge-based. Can't have emergency room services that are concierge-based. There's a lot of need for hospital-based services
I forgot about Jill. Sorry.
that is just not a model for. And the other thing I think we want to keep in mind, we have 1 million New Yorkers who are uninsured and they're not going to pay for.
Would they be insured once the ACA is
Yeah.
authorized them?
Yeah.
So we wouldn't have that
No, the 1% who are, the 1 million New Yorkers who are uninsured, they've been uninsured forever.
Despite the ACA.
Yeah.
Okay.
Yeah.
We have questions online that I
Yeah.
forgot about. Jill?
Sure. I did want to just jump on what Morton said because I was at state committee when they kind of basically killed the resolution or ended up really watering it down. So do not underestimate the influence on unions and people with their existing plans. Plus, the insurance agencies are going to go, very strong on putting out fear issues that it's going to all be a sort of a HMO and you're not going to be able to pick your doctor and all of this. But the influence of unions who have fought very, very strongly to get what they think is and is the highest quality care, plus people who already get very high quality care are going to be scared of this. And I get the sense because I support this very strongly, this bill, and I think it's important to get it through. But I think the stumbling blocks are being a little played down on your end, to be honest.
Well,
Well,
I
I would try to answer that, because
Yeah.
politically, that's why we're here. That's why we go to Community Board 1. We go with that. We're going to the various, like, political clubs downtown, which this is Northrop, is what we know. We're not downplaying the power of the unions. What we're trying to do is amplify the other voices by having all these other folks involved, and also getting enough people saying, well, it's only a couple of unions as opposed to all the unions who are for it. So we're not saying that this is not being blasé about the power of the public unions, but we think that if enough people are aware of just how many other unions are supporting it, it will make a difference. I just want to point out that there's actually enough sponsors in the assembly that it would probably pass if it got to the floor, but the problem is that it's a 19-19 vote in the Health Committee of the Assembly, and it's basically 5 Democrats who have been abstaining from voting. So they could easily break the tie. So one of the things we're looking at is also putting pressure on a couple of these Democrats. So again,
It still
a lot
doesn't,
of-
I understand what you're saying, but it still doesn't address the fears of people. Plus, somebody there had mentioned doctor utilization. I know from my personal experience, and I think everyone in this room has gotten this, well, it's 4 months, 6 months, 8 months to see a specialist now. I think that that's going to be another big issue. There's not enough doctors and not enough specialists right now in New York. I think these are important questions people are going to have. And I think there needs to be solid, strong answers to that, and I'm not hearing it.
Well, first of all, if doctors spent a lot less time fighting with insurance companies, it would be almost like doubling the number of doctors.
Yeah,
in New
they
York.
have staff who do that now. I don't think it's going to make a huge difference when you have to wait 8 months to see a specialist. I don't think it's
Well,
the insurance
again,
paperwork that's causing that.
If a doctor, if a doctor,
For my appointment.
if a doctor can see 2 patients a day, the waiting time is gonna be twice as long as if that doctor can see 4 patients a day.
Our last question will come from our board chair, Tammy Meltzer, online.
Thanks. I appreciate this. So I'm kind of a little skeptical, and I'll say this for a couple reasons. One, 3 out of 4 specialists that I see have all left for concierge practices that don't take insurance. Period. It's not just a one-off, it's a majority of the doctors that I've seen. Another doctor that I've asked as to why, they said because they don't want to deal with insurance at all. They don't even want to have staff who deals with insurance. They have the same staff that they had when they were in practice at a hospital at HSS, but they actually find that they said they would rather have the patient deal with it all. And then at the same time, you have pressure from the insurance companies where they won't reimburse you to any levels necessarily unless you're seeing an network doctor, depending on your plan. But the push lately has been from the different insurance plans year over year over year, as we're following, is if you want to go out of network, there is a much higher deductible, there's much less payment towards and things like that. So my concern is it all goes back to the root of it's extremely expensive to be a doctor in New York for the insurance and the liability insurance that they need to carry. And the concierge practices are a way that they can cut down on a lot of the paperwork that they have and concentrate on, yes, both patients, but it puts all the responsibility back on the consumer. And not everybody can pay $600 out of pocket, which seems to be the general going rate these days. I know I can't. So I'm out there now shopping for 4 new specialists. Your timing happens to be incredible coming to us now since October. Not a lot of fun. And this bill makes me more suspect that it's going to accelerate that trend. And I apologize for being a naysayer because that's not usually my thing, but that's what I am hearing.
Okay, you've made about a half a dozen arguments. I wasn't jotting them down as you went, but if we wanted to go through each one, we could do that. But what I did notice is that every single thing that you said is an argument for the New York Health Act. These are things that make you upset, and they should, but they are all arguments for the New York Health Act. Doctors who are demanding concierge fees because they have to spend so much time on administrative garbage. That's one argument for the New York Health Act.
It's not about the time, sir. I appreciate this, sir. Okay.
Well, that's what
It's
you
not
said.
it's not the time, it's the reimbursement. The reason why they no longer participate is the reimbursement rates.
Well, the New York Health Act is going to reimburse them more, and they're going to have to spend less time to earn that reimbursement, because they'll earn that reimbursement by the number of minutes they spend with you, not having to spend twice as much time fighting with the insurance company, for which they're not going to get paid by anybody. Again, if you can treat 4 patients a day, you're going to make twice as much money and help twice as many people as if you have time to treat 2 patients a day.
But
right?
No, because they're not the
Doctor who
ones.
you're complaining,
not the
excuse
ones
me, the
doing
doctor who you are complaining about, and you're right to complain, the reason that doctor is not seeing you promptly, the reason that doctor is charging you so much is because an insurance company is making your doctor spend time with them instead of with you, and is screwing him out of a fair reimbursement.
My
Simple.
they have a team of people who does it. He sees the same number of
That's
patients.
right, and you know what? Those people are not volunteers. Right? They get paid.
So
They
I'm
get
just going to give
paid
you
by
his
the
explanation
doctor.
to me.
They get paid by the doctor. Where does the doctor get that money from to pay those people to help him fight with the insurance company? The doctor gets that money from you. You like that? Is that good for you? Does that help you get health care? Does that help you save money? No.
He's not.
Basic point is that that there are real problems with the current system, but to use those problems and project that the New York Health Care Act is gonna have those problems, is sort of not, I'm not gonna say not fair, but I don't think it's actually an appropriate way to analyze the possibilities of the New York Health Act. Again, all these, like as Richard said, all these problems that you're saying exist in this current system. That we think that going to the single payer system, not the single provider, will benefit a lot of people. Now, apparently, Now, where I live, there's very few people I know who have concierge doctors, it's only, a few blocks away. So, it's not, I think for the majority of people, that's not gonna be an issue of like how they change their lives. I mean, this will radically change the lives of millions of New Yorkers. And that's what we're asking you to consider.
All right, it looks like I was mistaken. We have one member of the public who has a question. We'll get that answered, and then we're gonna move on to item number 2, the budget priorities for Bellevue Hospital.
Melanie, do you want to unmute yourself and speak?
Hi there. Can you hear me?
Yes.
Very well. Great. Thank you. Yeah, I actually was just raising my hand to chime in on something, but I think Dick went back and addressed it. So I just want to let everyone know I did put Dick Godfrey's email in the chat. I'm the executive director for the Campaign for New York Health. So we lead the coalition to pass the New York Health Act. I put our website in the chat as well as my email. So if there are additional questions, keep them coming, right? If you are skeptical, if you're having, lots of questions come up, that's normal. That's healthy, right? We want you to bring those questions forward and we will get you answers. We're big on transparency and we want to bring you along. But one thing that we do know is that these healthcare cuts that are coming from the federal government will be devastating. They will close hospitals. We will more than double our uninsured population in the city, and people will go without health insurance because they can no longer afford it. And this is even happening, by the way, to unions. NYSET's premiums went up 9%. UAW's premiums went up almost 6%. So even the good health insurance is getting to a point where it's not sustainable for everyone. And I think, the New York Health Act is the only plan right now at the state level that solves for all of these issues, right? And I think it's important to note that it's not going to solve every single healthcare problem out there, but it is a giant step in the right direction in centering healthcare and removing the profit motive and making sure everyone can get the care that they need and deserve. So thank you so much for your time. Thank you for letting me make a comment. And we look, forward to continuing with you.
So do you have another meeting to discuss this and then go?
We're going to try to discuss it at the end of this meeting.
Okay.
Whether or not the committee would like to try to either sign on to the resolution that you prepared, the draft, or create one of our own.
Right.
If we decide to do that, then we'll bring it to our full board meeting next Tuesday. You're welcome to come to that too. Of course, that's another public meeting. And that's another opportunity to speak, if you sign up to speak as well.
2 minutes.
Yeah.
2 minutes.
Yeah, only 2 minutes, but yeah, you could, try to state your case as quickly as possible of why you think people should be supporting it. The elected officials tend to attend that meeting, so you have their ears as well. And, I'll certainly let you know whether or not we pass the resolution
I
or not.
appreciate you.
Yeah, absolutely.
Sorry.
And I
went so long.
probably will try to get you, if possible, in front of some members of the Survivor Steering Committee and or possibly some responders to see what they have to say about this too.
I mean, it takes more time to talk to the rest of the community board or, the survivors committee. I mean, that's
Well, that's a
separate thing.
yeah.
Okay.
But on behalf of the 9/11 survivors in the community.
Right.
Yeah.
So.
Thank you.
Thank you. You're welcome to stay. You don't have to go. We're not kicking you out, but we just have to move on to the next item.
Appreciate it.
Thank you.
Hanging in
And
there.
again,
We went so long.
you've got my email address. If there are more questions, email me. I'll respond.
Yes, thank you so
Thank
much
you
for
so
Thank you very
providing
much
that.
for your time. But
You, Assemblyman.
Good
And
night.
Renee,
very
if you
much.
want to be closer to one of the owls,
Okay.
you're next.
Thank you so much. Thank you
Thank
so
you.
much for having us here tonight. I'm here with Karen Moore, who is the chair of the Bellevue CAB, the Citizen Advisory Board. We're here to make an ask of you. We were going to ask you to support 3 things for Bellevue. First is to make permanent the fee for service upper payment limit statute. It's going to expire on March 31st, 2026. And this is an enhanced Medicaid rate add-on that reflects the actual cost and utilization of services at health and hospitals. So what that means is Medicaid is being paid at the same rate as Medicare right now. That statute expires and it's going to get paid less. We're asking you to, let's keep that statute, let's make it permanent. Number 2, We want to make permanent the telehealth payment parity statute. That's also going to expire on March 31st, 2026. What does that mean? It means that telehealth would get paid less than the actual visit of going to the doctor. And I'll tell you a little bit more about why telehealth is really important. And the final ask that we're asking you to support is to advocate for safety net provider parity and equitable distribution of Medicaid funds so people like Health and Hospitals Bellevue can cover the full cost of delivering care. There's a huge gap between what it costs and what they're being paid. Did you want to add something, Karen? Nope. We have, these are our slides that we have. I'm going to do this as quickly as possible because I know you guys probably want to get out of here. Bellevue is a part of Health and Hospitals, largest municipal healthcare system in the United States. It includes 11 major hospitals, community clinics, nursing homes, and it serves more than 1 million patients per year. Big thing, regardless of their ability to pay. It has more than 43,000 employees, 11th largest employer in New York City, and its 2026 proposed budget is $13.5 billion with a B. I wanted to say 65% of adult patients are uninsured or they're reliant on Medicaid, compared to the private nonprofit hospitals. Only 25 to 28% of their patients are reliant on Medicaid. As such, Bellevue is considered a safety net hospital because 30% of its patients are reliant on Medicaid or they don't have any health insurance at all. Just a little bit of information about Bellevue, located on 28th Street and First Avenue. It's the only tertiary referral hospital for complex care. What does tertiary mean? It's the one place that provides specialized care so that if you are, say, at Coney Island Hospital, and you have something very rare or complex, you're going to be transferred to Bellevue. Bellevue has 844 patient beds. It has 520,000 outpatient encounters last year and 110,000 ER visits. I just want to say, because you may be interested in this, the ER and outpatient load increased since the closing of Mount Sinai Beth Israel, but we can't give you the actual numbers because we're not allowed to say like, oh, are you from Mount Sinai? Did you come here? 60% of Bellevue's patients are on Medicaid. Medicaid reimburses only about 70% of the actual cost, so you can get how that wreaks havoc with their budget. Just to give you some context, Bellevue is nationally recognized in trauma, oncology, stroke, heart failure, child psych evaluations, perinatal care, and diabetes management. And again, just wanted to highlight, Bellevue takes all comers, regardless of ability to pay, immigration, or insurance status. You can walk in the door and you will get cared for. A little bit about Medicaid. It's the largest source of healthcare coverage in the United States. Thank you, Chuck. In 2024, federal physical, the year cost was $900 billion, with about $620 billion provided by the federal government and $280 billion provided by the states. How does it work? States administer their own programs within the broad parameters set by the federal government. In New York State, the federal government pays about 50% of the Medicaid reimbursement. And then additional funds go to the New York City hospitals in the form of supplemental Medicaid payments. And that offsets indigent care and makes up some of the shortfall relative to Medicare. But even with these funds, hospitals that serve a disproportionate number of Medicaid patients still really struggle. What are the income limits? It's 137% of federal poverty level, which is about 22,000 for an individual, 44,000 for a family of 4. Traditional Medicaid covers low-income children, pregnant women, dependents of parents of dependent children, adults, people with disabilities. What else can I say to you? You guys know about Medicaid. Do you want me to go through what Medicaid is? You know it? Okay. I'm gonna jump, so I know you guys are, okay. I just want to talk a little bit about HR 1, which you might know is the big, beautiful bill, which we're not going to call it that. We're going to call it HR 1. And it doesn't end Medicaid. What it does is it restructures it in a way that's going to reduce enrollment, federal payments, and flexibility over time. So what's happening is Congress is teeing up about $1 trillion in federal healthcare spending cuts over the next 10 years, right? And Medicaid is going to take the biggest hit. So it's important to know there's 2 things happening on parallel tracks. It's easy to mix them up. First, the ACA marketplace subsidy, they have expired. We know this, right? And unless Congress renews them, this is gonna affect people buying insurance on the exchange, but it's not gonna affect Medicaid eligibility. That's a separate sort of pot, if you will. So the Medicaid cuts are structural, and they're gonna be phased in from 2025 to 2028. And what it's gonna do, it's gonna reduce who qualifies, how long their coverage lasts, and how much the providers get, right? New York's pretty generous. Medicaid covers adults up to 138% of the federal poverty level, pregnant women, qualified immigrants, documented children, pregnant women, and adults over 65. None of the Medicaid requirements are going to be automatically repealed. Instead, federal government is going to make it harder and more expensive for states like New York to maintain it by changing the rules in ways that make staying covered harder, right? So what does it mean? It means that the federal government is going to pay New York less in 2025 and increasing in 2026. Washington's going to send less money to New York for Medicaid. And then we know this, people are going to have to prove that they're working, studying, or volunteering. So starting in 2027, many adults on Medicaid are going to have to show 80 hours a month of work, school, or volunteer activity. And if you don't do the paperwork, you're going to lose the coverage, even if you're entitled to it. They're just going to cut you right off, right? And there's going to be less backdated coverage and retroactive coverage. Right now, if you get sick and you sign up for Medicaid, it can cover bills from the last 6 months, right? That's going to drop to 30 days in 2027. So it's going to be 6-month renewals instead of 1-year renewals. And so, each year you have to renew your health insurance. That's going to drop to 6 months for Medicaid. And that's going to be a pain. People are going to drop off just because they're going to forget. And it's going to mean that even if they're entitled and they didn't do the paperwork, they're done. Right. Exactly. And then the other thing is the hospitals are going to get paid less, which is the reduction of the Medicaid supplemental reimbursement rate, which is in 2028, the special Medicaid payments that keep safety net hospitals like Bellevue open are going to get cut. And then there's some new costs for very low income people called required cost sharing. And that means they're going to have to pay some out of pocket costs like some copays, and that's going to be determined in 2028. So what's going to happen? People are just going to fall off, right? It's going to be due to paperwork, language barriers, housing insecurity. They could be in the hospital or just churn. You forgot to put in your paperwork on time, you're done. And even small fees can cause people to delay their care. You know that. Like if you don't have the money, then you don't go and you think, oh, I'll get better. And then it snowballs, right? And then when they finally show up, they're sicker and the treatment costs more. We heard that from Senator Godfrey just now. People are going to rely more on places like Bellevue as a result of this HR 1 when there's likely to be a significant increase in unreimbursed care. The HR 1 bill, it's estimated that 950,000 people in New York City are going to be affected with a statewide loss of 78,000 healthcare jobs and 136,000 jobs in related economic activity. So what can you guys do? First, we're asking you, please, we want the fee-for-service upper payment limit statute, which is due to expire, be made permanent. So Medicaid doesn't cover the cost of care for hospitals like Bellevue. Currently, right now, the law has an enhanced fee for Medicaid, and that matches the Medicare rates. And so that's going to right now, the statute lets states pay hospital up to what Medicare would pay for the same services provided under Medicare. The law was brought in 2020. It was renewed once, but it's going to expire. So our request is to make the law permanent, or extend it, but we want to make it permanent if we can. That would allow New York State to legally supplement Medicaid and bring it up to Medicare rates. So Bellevue is not punished for treating Medicaid patients. Again, 60% of the Bellevue patients are on Medicaid. Without this law, Bellevue is unlikely to have the cash they need to provide the care to their patients. So that's number one of the resolution that we're asking you to support. Second, ask the legislators to make the telehealth payment parity statute, which is also going to expire, permanent. Right now, it requires private insurers and Medicaid pay for telehealth at exactly the same rate as in-person services. We all know Bellevue's patients use telehealth a lot. They use it due to work schedules, transportation barriers, childcare, and disability. If those visits get paid at a lower rate, Bellevue's going to lose the revenue. Even if demand for telehealth stays high, even if they get more people using telehealth and they get paid less, how are they going to provide for that? In 2025, Bellevue reported 105 773 telehealth visits, and it's going up. So we're advocating and ask that you would advocate that the parity statute that it gets paid at the current rate remain. So people have access to virtual care. Third, the last thing is just to ensure that there's safety net provider parity and equitable distribution of Medicaid funds. So essential providers like health and hospitals can cover the full cost of delivering care. In the recent budget cycles, New York scaled back or they left gaps in supplemental funding that hospitals like Bellevue were counting on for their capital needs, keeping the elevators running and all those wonderful things. This is the support that helps them, keeps the lights on and handles the operating costs. New York, as part of the fiscal year 2025 state budget, codified into law effective April 1st, 2024, a provision known as the Safety Net Transformation Program. And it's statutorily authorized New York to strengthen safety net hospitals with capital and operating support. It exists in the law right now, but the actual funding is set through annual budgets rather than as a permanently funded entitlement. So basically, we need the entitlement, we need the funding to allow that law to operate, and that's what we're asking you to support. So we wish to advocate. We want to highlight how important Bellevue is. Bellevue serves the entire city, a lot in Manhattan. I don't think you
So
guys.
again, we have a nuanced relationship with Bellevue as well. Bellevue is one of the centers of excellence.
Mhm.
So again, it services our 9/11, very heavily 9/11 impacted community.
Yeah.
Although the actual clinic itself has been moved out.
Yeah.
There are still some services that we have to receive at the hospital. Typically the 7th floor of the H building.
Mhm.
So we have that connection to Bellevue. We don't want to see Bellevue go away.
This is not the stuff that we're advocating for.
And I know this is for the hospital, but I'm saying we have a
Yeah.
special relationship with Bellevue in this community. So I don't think that our members are gonna want to let it run into difficulty.
Yeah.
And
But this is for all of H&H.
no, I understand, yes.
I went through that really, really quickly because I wanted to minimize the time because I know you guys know about Bellevue. But it is a 3 ask. We're hopeful that you will support a resolution in favor of Bellevue and in favor of these funding asks, the parity statutes, the extension of those and the.
So if there's any questions in the room, we can go first and then Zach, can you see if there's anyone down there? Diane?
The first presentation, I mean, and this is a big if, the
Uh-huh.
New York Health Act should, if it were to pass, would that eliminate, how would that affect?
My understanding of what I heard tonight, and this is just my understanding, it would seem that this would bring parity up, everybody would get paid the same regardless. So it would seem to do away with Medicare and Medicaid, the differential in payments. So it would seem that that would benefit Bellevue in a way, in a really good way. Again, that's my understanding, and I don't know if you.
The same.
Mm-hmm.
But
I
it
think
seems
that
like
health
because
act is a law.
many of your patients are below the
Uninsured
poverty
or,
line
yeah.
or have no insurance, this would indeed help us.
This would, my understanding it would really, really help Bellevue.
And again, preventative medicine.
60% of the patients at Bellevue are on Medicaid or don't have health insurance.
Does anything done for Bellevue automatically also support Gouverneur or no?
It's all of them.
It's all of
Oh,
that.
all of
So
them.
this is all the 11, the healthcare clinics, all of it within the health and hospitals ecosystem.
Okay.
We're here from Bellevue,
We
but
introduced it as a
yeah.
Bellevue thing, but it's an H and
yeah,
H.
yeah, we're here from the Bellevue CAB, but we're also, it's an H&H asset.
Okay.
Every health and hospitals, clinic, hospital is asking for exactly the same
That's what I
thing.
was trying to say.
Okay,
Yeah.
okay, thank you.
You're asking for it together.
No, you guys are for it.
Together.
Everybody, yeah.
So you said there's an increase in the telehealth?
Mhm.
Are you prepared for that?
So-
Technically?
So
Or
yes.
will that be another ask in terms of the upgrade and the systems?
Right now, I can say that they're ready for it because it's been going through the roof. They've really seen an increase in the number of people taking it up. And the reason they want the parity payment is if it continues, at least they can, it would be half a dozen, 1/6 of the other. If you're coming into the office or you're being seen online, with the parity payments, you're getting paid the same. So you're asking either way, if the person walks in or they're doing it over, the computers.
And right now you're able to.
Right now, they're able to handle it, particularly with behavioral health. It's really strengthened the number, I think it's 80% of, we were seeing a really high number of no-shows for behavioral health coming in physically, to see the doctor, and then it was offered on telehealth, and it's gone through the roof. I think it's 80% increase, is that?
Awesome.
No, it wasn't. The number's loosey-goosey. It was a very, because I want to be sure I'm not giving out incorrect info. Approximately 70 to 85% of behavioral health patients were
No
no-shows.
shows.
For HMH or for Bellevue?
For Bellevue specifically.
With telehealth, that no-show rate dropped to below 50. I think it's
Yeah.
really somewhere in the 20s.
Yeah.
And Bellevue is now, we don't know what Bellevue will ask for in the future. 'Cause, you know, we're not fiscal, we're the ag board. But right now, they do have funding in place for upgrading the wireless.
Okay. That's,
In anticipation, because
yeah,
telehealth
that was
started in
my question.
2020,
Yeah.
you know?
So we have Tammy online.
Nope, go to Jill first, please.
Oh, Jill, online.
I'm glad to hear that this isn't just Bellevue, that it is also all of the hospitals, because I think if we do a resolution, that Gouverneur being included would be important. The one question I have that I disagree with a little bit, because I think to be realistic about what's going to happen to budgets with federal cuts means that looking closer at things like telehealth, which I agree are essential, but I just don't see it equivalent in terms of cost as an in-person visit for all the services and people involved in an in-person visit. I do support it. I think for mental health issues, it's an incredible thing, but you're not even taking someone's blood pressure. You're not really having all of those extra services that do come with in person. So I really wonder how strong a case there is, considering there's going to be cuts in asking for an equivalency on telehealth.
Okay, so I think maybe perhaps I didn't explain it well enough. So telehealth is used primarily for ambulatory care and behavioral health. So it's not like I'm saying you're going to your primary care and you're going to get paid the same amount if you see your psychiatrist, right? What we're saying is if you were to see your psychiatrist in person, right, if the law expires, that going there personally to the office would cost you more than having that same appointment online. So it's not that you're going to get, a scan or something else, and we're asking for equivalency in that way. What we're saying is, it doesn't, if you're getting ambulatory care, which doesn't require a scan or whatever, or if you're getting a behavioral health care, whether you walk in the door or whether you're doing it over the screen, we're asking for parity in payment. It's not that the care would be different. You're getting exactly the same care, and we want them to be paid.
Yes, but the costs
similar.
have to be lower on the hospital's end for telehealth. Just talking about even the check-in person and the security person and the nurse who takes your blood pressure all the time. And is telehealth honestly the same for this as an in-person visit in terms of costs to the hospital?
I can't break down in terms of actual costs, like I don't have that data for you, but I will say it increases productivity for the hospital and they're providing exactly the same service. So whether it costs more to keep the lights on in the building versus keep a modem on, I don't have that data for you, and I can certainly find that information.
The other part of that is if whatever you receive in the telehealth visit, that goes in the same pot of money.
It does.
As everything.
Thank you.
So the whole point is that we want to keep the hospitals running. So if telehealth helps their budget, I'm for it. And I'm for it being considered in parity with an in-person visit. I agree with you to some extent. It is different, but I don't care. I want to keep the hospital running. So
Keep the lights on.
And people use telehealth at a greater rate. If the telehealth gets reimbursed at a lower rate, and people start using that, 90% of the patients use that.
Yeah.
Then, maybe it does fund some of the in-person. I don't know. I'd have to check that, but to Pat's point, that's what we're advocating. To keep the hospital open, because again, we're not being
Yeah,
reimbursed.
I want the hospital open, but that's not what I'm saying. But thank you.
I agree with, right, thank you.
Tammy?
So I was going to go down the same road Jill has. So I'm going to leave Jill's comments state. I think the priority is to keeping the hospital open and fully funding, and everything is exactly where we want to be. I can see the value and understanding why mental health services online versus in person is one thing, but I think I do agree that there is several more steps that are involved with being in person for higher costs than being online. And sometimes online, you're not actually meeting with the provider, but you're meeting with only the PA, the nurse, the associate, the resident, whomever it is, who the doctor has supervision over. But unlike when you're in person, where you meet that person, they take all your vitals, and then the doctor comes in to see you, telehealth doesn't have the two-step process on that. It's usually a one-step. You tune in, and whoever you're meeting with, you're meeting. Maybe there's a flyby with your doctor, maybe there's not. At least that's been my experience, right?
And
Unless
mine's
it's
been the opposite. I've
unless-
always met with a doctor, not a
Well,
PA
some-
or anything. I've always
You got
met
that good
with.
union insurance.
So my question, exactly, you definitely might have better insurance than I do. My question starts to come back to, we want to support Bellevue and H&H. They are our 9/11 hospital. I still need to do my paperwork, so we'll just leave that at that. And the paperwork's huge. So there's that. But can we break apart what you're asking if the board does not support part 1? Can we do a resolution that supports parts 2 and 3? Can we leave some of the parts in or out?
Yes.
And how can we?
Absolutely.
Yeah, I think that's there's an important nuance to be in here that I think needs obviously different experiences and different discussions. But then my other question is timing. Like the prior speaker, they've been fighting for a bill for 6 years. God bless them, right? And hopefully we will get across the bar to have healthcare for all and quality medical services for all, et cetera, et cetera. What's your timeline here? I know the initial budget has come out from the governor's office. What timeline are you guys on for a resolution?
So we're on a really quick timeline. That's why we wanted to come now, and we're really pushy about our asking to come. I apologize and thank you for accommodating us. We have a lobby day, which is coming up in February on the 7th. And that's when 10th, and that's when we lobby all of our electeds. They're coming to meet with us, and we tell them, these are the asks, and these are the people who are supporting the ask, which is why we're doing our Horse and Pony Show to all the community boards and the electeds. So we would ask if you have the resolution, if you get it before that date to us. In terms of what the resolution contains, we're asking for these 3 asks, but obviously every community board, what you wish to support, and you know how you want to say it. And we gave you just sort of a sample draft, but obviously it's up to you to support the pieces that you think are important and the pieces that you think don't, or what you think needs to be changed in that. I am happy, and I will come back to you as soon as I can with information on, for example, behavioral health cost of an appointment, to see if I can get that data, because I think that's important. I think that's an important point. I don't have the information on that, like what are the differentials in costs? We'll see if that makes any difference to your position.
What's gonna happen with this one? We'll take a vote. I expect that we'll decide to do a resolution. Obviously, that's not guaranteed. We will start out with the one that you provided to us. We make changes here, and whatever we do can get changed again at the full board on Tuesday. And that will be ultimately where the decision is as to whether or not this community board supports.
Okay.
Yeah,
Sure. Absolutely. We're just grateful for the opportunity to come here to explain what's going on with Bellevue and Health and Hospitals and any support. you can
We
provide.
appreciate having you.
Very much appreciated.
Thank you.
Thank you.
Thank you, thank you.
Thank you.
Thank you.
So we will move on now to discussion with the quality of life issues at the American Stock Exchange building.
Bye. Thank you.
Hey, Mariama,
Uh-huh.
in the essence of trying to get the work done, can I,
Yeah.
I need to go and come back, and I know there's a quorum issue. Can you give me an idea for timing?
Do you want to take a quick vote now to do it, to do it or not, and then
What, for this?
we'll visit the actual resolution later?
For the Health and Hospitals one.
Or just give me a time to come back. I don't mind. I can go and come back.
Want to come back at 8:15?
We can do it now. I
We can take a. yeah,
I
we'll
think
call the
we
question
should do it
second.
now.
All right, let's do it.
And then,
Call the question.
you know, when she comes back, if there's any other things, but at least we have something to
We're
work
only
with.
doing the health.
Okay, so, yeah, is anybody opposed to supporting the Health and Hospital resolution? Anybody recusing?
Right. I'm abstaining because there is an aspect of the telehealth that I think needs to be tweaked in there. I'm not comfortable with where it sits. If you want to redo that when I come back at 8:15, I'm fine with that, but I
Yeah.
think
Yeah,
there's,
while we're doing the straw, like the vote, and then we'll come back and revisit after
Right.
this presentation.
Exactly.
What about Jill?
So, Jill? what's your
I
vote?
have the same feeling on the telehealth, but I support
two
the bill
abstentions?
without it. I mean, the reso.
Okay, two abstentions.
So, no, but you don't want to abstain on the whole thing. You just want to.
Whether or not, no, not the actual resolution itself, whether or not to do one. So you want to put it down.
So if we
You
run
don't
up
have to mark it
the
down.
Reso, where we supported the other two asks and we left out the telehealth, you would be okay? Baby, but my other question is, I'm sorry,
We'll figure that out after.
what did she say we could have in Reso?
She needed it as soon as possible because she wrote something early February.
I think that the telehealth could be a separate resolution that you do a little bit more nuanced because perhaps,
Yeah.
again, the committee has to do what the committee feels is
We can
right.
do whatever we want.
Yeah.
But,
Alright, so now we know what you
so now we know we're definitely doing the resolution. We're gonna move on to the other item.
Okay.
Okay. Sorry.
Okay.
Thank you, no problem. Are we able to get the PowerPoint up on the,
Yeah, give me 1 sec.
okay. While Zach's doing that, I'll introduce myself. I'm Natasha Lifton. I'm the Managing Director of External Affairs at Trinity Church, located at Broadway and Wall Street. I am joined by our Chief Legal Officer, Kenneth Austin, who's here with us as well. I just want to thank you for the time. We really appreciate time you're giving us tonight to discuss this issue. Just waiting for okay. Okay, so here's our quick agenda. Oops. Talk a little bit about Trinity, give you an overview of the issue, neighborhood stakeholders we've been talking to, some of the safety issues that we're dealing with, and then our ask around a resolution. Trinity Church, if you didn't know, is a vibrant and growing Episcopal parish. It was founded in 1697. It's been at the center of the city's religious and civic life. Since then, we work for justice, serve our neighbors, and bring people together to experience God's love in community. Our outreach includes 20 weekly worship services, youth programs, both on-site and in the community, food assistance 7 days a week, support for asylum seekers and immigrants, housing for the elderly, charitable giving of more than 400 million since 2019, and free music and educational events. Trinity's program is run out of our flagship office building, which is located at 76 Trinity Place, and also has an entrance at 107 Greenwich Street. This includes for our youth program, which serves about 700 young people, and the food distribution program, which serves about 1,000 people a month. Our neighbor directly to the north is the former American Stock Exchange building located at 86 Trinity Place. As you might all be aware, despite multiple plans to develop the site, it remains fallow and has fallen into a state of significant disrepair. This map shows the red is 86 Trinity Place, the American Stock Exchange building. The tall tower with the purple arrow is Trinity's headquarter building. The darker blue arrow is a building that houses two public schools, Leadership and Public Service, and a school without walls. And then the lighter blue is the location of the High School for Economics and Finance. So all of these schools are on the block next to the building, and we serve large numbers of students in our after-school program from all three of these schools. So in addition to the three schools who we've been in contact with their principals, and their principals are also very concerned about the conditions in the building, there have been issues with kids being able to get up on the roof from the school building that's directly north of 86 Trinity Place because it wasn't secured. That's been taken care of in terms of the principals figuring out a solution, but definitely a significant safety concern. The Downtown Alliance is also very supportive of us working with you all to address this issue. And we know that there are many neighborhood residents who are concerned as well. We might have some neighborhood residents who are online with us. So happy to hear from them if they're here. So some of the safety issues that we're dealing with, the condition of the building is a safety hazard. It presents a risk for Trinity staff, our parishioners, and those from the community we serve. So folks, the young people who come into our building for our after school program, the people who come for our emergency food program, the people who come for our music and education offerings, all of these folks are at risk. So are the students and the staff.
It's all internal, no potential danger to pedestrians?
And to pedestrians, yes. So anyone walking on the street, on the sidewalk in front of the building, is at risk, but I'll explain why in a minute. It also presents risks to the students and staff of our neighboring public schools, as well as the broader community, to your point. The hazards include falling debris from the southern exterior wall, rodents, accumulation of trash, and loitering. This includes an unstable parapet, which we just found out about and is in need of immediate attention. All of these issues have been the subject of numerous violation notices issued by the Department of Buildings.
Did we say they had 20 violations?
They have at least 20 violations, yeah. So what does this mean for us? It means that we are unable to use our outdoor terraces, and we have had to erect sheds on those terraces to protect from fallen debris. We have made repeated efforts to work with the owners of 86 Trinity Place, but they have thus far failed to remediate the situation. So this just visually shows, so this is our building, 76 Trinity Place, and if you see up top there, that is one of the sheds that we have had to install ourselves at our own cost to protect against the falling debris from that southern exterior wall of 86 Trinity Place. Here's just a snapshot of the conditions on the street. It's dirty, there's garbage, it's not safe, it's not well lit. The shed that is there that was put up has been up since 2018. So it's been up there for quite a long time.
Well, DDC put up the new shed and extended the shed.
Yes.
Yeah.
Yeah.
And the lighting is better, because I've actually.
It's a little bit better, yeah.
Yeah.
Yeah, since they did that. So what are we asking? We are asking that the community board pass a resolution asking that the owners of 86 Trinity Place promptly repair the southern exterior wall, including this parapet, remove any safety hazard that affect our headquarters at 76 Trinity Place and our neighbors. We also request that any such repair include a hands-on inspection of the southern exterior wall to assure that it's structurally sound, as well as in compliance with all applicable local laws. We've drafted a resolution to this effect and we very much appreciate the board's consideration. We're happy to come back when the full board meets next week, and happy to take any additional questions or thoughts or comments.
So before we go, I'm sorry, before we continue, so you spoke to the owner of 86 today, right?
I reached out by email and, earlier this week, and they responded, but they said they couldn't make it to this meeting due to the short timing. And they asked to, postpone this item.
Until when?
They didn't say.
Oh, I thought they said they'd come back and they'd come
I
back.
offered, I told them they should, come in February, or offer them, time in February, but I didn't get a response to that yet.
Okay, so we're hoping then that they'll respond.
I would propose that we support this first of all. I think the therefore be resolved could be strengthened with even just like the word immediately, like immediately take steps or measures to promptly repair. Because it doesn't, it's not very clear here that they have to do this like right now, to me.
Yeah.
And I would like to include, I'm sorry, and tell me, Natasha, but I feel as though there needs to be an ongoing, consistent communication with them. They need to have someone that you can speak to.
Yes,
Immediately.
we have been trying, yes, we have been trying to make that kind of connection, but right now, and Kenneth can speak more to this, right now, our primary sources of communication is their attorneys. So it's very difficult to get sort of immediate.
Nobody's on the side.
What does their attorney have to say?
The attorney, says, oh, well, I have to get back to my client, and it's been since August that we've been in contact with the attorneys. But, we have not had any direct contact with them, and so actually we were surprised that something came directly from, the owner to the community board, because we've not, that person has never been in contact with us.
So their attorney has said nothing about the fact that their debris could kill someone.
Not, hasn't reached out, so I have.
But if somebody got hurt in Trinity because of their stuff, they're probably gonna go after Trinity, right?
Well, that's one of the issues. I think we're concerned about, the public, and we're concerned about mitigating, which is why.
And your staff.
Which, exactly, and the staff and the school to come to those. And so we, out of our own pockets, have put up the protections that Natasha just showed on the fifth floor and the eighth floor.
As a committee, we've been on record forever as far as this whole shed thing in our community. And how did this get overlooked in all the,
Yeah.
Because they haven't been there.
Well, because also these people certified, like, we're doing everything great, we're working, we're gonna be finished at this date, and they get to put down whatever they want.
We haven't heard
Until there's a violation, that's when the Department of Building.
so can we look at we can do our records and see how many times they said, we're doing this,
But
2018?
Since, my understanding is since before COVID, when we did the walkthrough.
Right, that was just after COVID, because that was,
After COVID?
it was after COVID because I had just started at Trinity and I started in September of 2020. So we did that tour. I can look up all the dates. I have everything for you, but we did that tour. That's when the NED, the Soho House development was under, active progress. We took that tour, so I think that was in 2022. But the construction is completely stopped now, as you
Right.
know, and it's.
So they had a full
stop
scope in there.
Yes, they did.
Renovating. And then after that, suddenly they disappeared and we didn't hear anything. Right?
Okay, Diane.
What happened to local law 11 that was supposed to prevent, or protect buildings, whatever, from letting.
The law Adams passed, right?
Even before that, somebody, my friend's sister got killed by falling debris and they had.
Didn't Adams update that?
Yeah, but local 11 added the requirement, I don't know if it added it, but it does require, the sidewalk sheds to protect you from falling debris, and that's what's there, and has been there since.
And the bonding.
Add something to that where they have to come down within a certain amount of
There's
time.
there's new
There's a work
legislation.
has to be done.
Or they would.
Or you get a
install-
fine.
They would go
Fine.
Yeah, there's new legislation that goes into effect in this year where they're gonna have
Oh,
stronger requirements to.
Oh, so that's not-
okay, so it hasn't started yet. You're in the grandfather period.
Right, that's the Eric Botcher legislation.
And really, that's kind of not the issue. The issue is that they are not
They're
responsible.
not being responsive. Because
The
they,
issue
but
is
I
that
think
they're
they
not
don't have to.
Good,
Because it's like this
They're not being
gray area
good.
right now.
Have you
DDC
considered,
had to put up the new shed and pay for it. You had to put up the shed on your building and pay for it.
Yeah.
What are they doing? They're doing nothing.
have you considered taking any legal action for nuisance or trespass?
I'll let the lawyer answer that question.
Well, we're trying to figure out exactly what the cause of action would be for nuisance and,
Well, if they're actually,
no one's been killed yet or.
no, but if there actually is there debris, falling on your property, that could be nuisance or trespass. And there are other neighbors who sued other neighbors for stuff like that.
Well, can't you sue them because you had to pay for protection of your building and your staff?
Yeah, we're still in the process of adding protection.
That you're paying for.
The parapet issue, we're adding more. So, we may end up in that position, But the immediate concern is making sure that, the staff, public, parishioners and others who receive services are getting the kind of protection that they need from anything that might fall. And
I just want to bring up an additional issue that came up today on the walkthrough that Zach and I had. So right outside, right as the shed stops, the south side where the shed stops, right there on the sidewalk, they have to, DDC has to gain access for the sewer system, not in the street, on the sidewalk. And they need to extend that shed another 16 feet. And so they want to discuss with you at their cost, at their expense, but they cannot do any work. So this whole Trinity project, infrastructure project that's going on is is kind of at a halt at that point, because they can't do any work unless they extend the shed 16 feet. So that's something that they need to get permission from you to be able to do, because it's technically on your property.
Any questions online?
People, they wanna do that, why don't they just get? They need.
Two different things. Two different things.
Joe, you have a question?
The hand's been up. So if I would put a hand down.
I think we can call the question on this one, no?
Sorry, I didn't
No,
put
I
my
mean-
hand down. Sorry.
We're gonna
Sorry.
support it.
We're gonna support it, but don't we wanna add things like they need to provide, I mean, I don't know how we're gonna make them do it. They need to provide a contact that someone you can contact immediately when there is an issue. So, you've kind of been in limbo about this falling debris and you had to take it upon yourselves.
So those are
to-
two things that we want to add to the resolution and therefore
You
be
should be
resolved
reimbursed
immediately.
also, right?
Yeah,
I'm here while we
Yeah.
okay.
do the
You should be
resolution.
reimbursed for the money that you had to lay out to protect your staff, parishioners, neighbors, students, because of their structure being faulty. Through no fault of your own, right? Anything
So
else
you're
you
okay
wanna
with those two suggestions that
Yes.
you made?
so I think there was a third one, the first one you mentioned was immediate.
And that they're.
Yeah. Yeah, a contact.
Immediate repair.
And then-
Immediately take measures to repair the.
To repair.
Yeah,
And then a constant contact.
yeah,
And then reimbursement.
and reimbursement.
Is there anything else?
We've
like
also had to hire engineers and
So we could just say
that?
like,
Whatever
whatever costs.
whatever
And
costs
money
to
to
do
add
that.
Sort of all encompassing
I mean,
water.
we're just talking. Now let's get them to do this.
I would just add one thing that, just for your consideration, which is, and I just learned about this today from another staff member who indicated that, the garbage and, that it would be good to have, so the kids are not going through, if there are needles or other garbage, just have someone to come through and just
Sanitation.
and sweep every so often.
You mean under the scaffold?
Oh, and the garbage on the site, oh. okay.
There was a gentleman sleeping under there today.
So that's what I heard, she mentioned that as
Yeah.
well.
Is that sanitation there?
No, they're responsible for their own sidewalk.
Oh, okay.
Yeah.
So we're calling on them to do that.
Yeah, they should clean their own sidewalk.
I don't know how we enforce this, but I think that we should at least add all those things to the act.
Okay.
And then hopefully, if they really do say they'll come back in February, we can continue this conversation.
Well, we have a date, we'll have a date in February and.
So what does the Department of Buildings have to do with any of this? We can't get the Department of Buildings.
Maybe they can come in February, because that's the month that.
They have, I mean, they have a bunch of violations, and
So can't-
they have a stop work order,
So
but
can't we
that's,
ask DOB to come to our meeting?
we
If
can,
they-
I'm not sure for what purpose, they would just say
Face
that
to
they have
face.
a lot of violations.
Face to face. Is there anything else is there
Got a
any?
critical situation going on here and we need resolution immediately.
Is DOB the enforcer, or do they just issue violations and somebody else is the enforcer?
There's no real,
There's no enforcer.
I mean, DOP does enforcement by violations, which.
But if somebody doesn't clear the violations, is there,
They just get more
there's no enforcement, there's more violations? Okay.
It's
All right,
just-
well, maybe we don't need them.
Well, I still think it's a good thing.
You said they could at least hear.
They welcome it if you had someone come from DOB.
Yeah.
Especially if the owner has a real.
So we can invite them.
We can invite them, I don't see it.
The lovely gentleman that you said, be the acting
We've actually,
commissioner in
DOB
HPP.
used to
Is
come.
now at DOB.
Yeah.
Meg took on, he might be, I don't know if he's involved in this, but he was good at, HPD. So
Yeah.
maybe he's good at DOB.
Is there anything
That's the
else you
hope.
want to add to this?
It's just for the DDC sidewalk shed, extending into your property, you guys are okay with that?
Yeah, we have a facilities team, I'm sure they'd be happy to meet with them. And I think Natasha, we would be happy to, have a tour with them and understand what.
Have they not approached you about this? They said that they had actually reached out and that they were at standstill about this.
Oh, I don't, have they ever reached out to me?
Oh, I understood that there was, I mean, if I understand it correctly, that there was a community board that they would set doing, but no, we're not, it was just the community board. people.
Right.
Right.
And so we would have to set up.
No, but I don't
your
mean
own
about,
tour.
no, but I don't mean about the tour. They said they reached out about extending the sidewalk shed at their cost. At their, they would pay for it, the 16 feet that they needed to extend it south. They said they had reached out to you all.
We'd be happy to.
Okay, so-
Someone, wait a minute, kind of lost contact.
Okay, so it's okay if we get you guys connected.
Yeah.
So the people that are not doing what they're supposed to do as far as the shed need this particular thing to happen.
No. The DDC
Right.
who's doing all of our infrastructure projects that we talk about all the
Right.
time. They're doing a Trinity Street
Right.
infrastructure project. They need the shed, totally different than the owner of the stock exchange. So
Okay.
This is difficult to understand, because I had the same question as you when I
No,
was.
yeah,
on
because
site.
I'm looking to put a pressure point, because like if you need
Two
something,
different things.
if you need to do this in order to get
Two
that.
different things, and unfortunately Trinity.
Oh, yeah.
Okay,
being
so
asked to
can
do
we
two
ask
different
them,
things.
say, look, we got this other problem over here, can we get a little help?
No, because it's two different things. It's two different
I
things.
was two little things
DDC
but
to
for
get
the
on with
same
their project.
project.
DDC was asking us for help also to remove the scaffolding at American Stock Exchange building, because it would help them do their work if there was no scaffolding at all. But obviously they need it for protection right now for people
Right.
walking by.
So they've got to.
But if they fixed up their facade, then they wouldn't need the shed.
The only way is if you want the DDC project.
Yeah.
We want to get
Yeah, I think we
DDC
should
out
go.
of the picture. We want them to proceed with their project.
Yeah.
Still another 2 years.
So do we.
project. So we want it done.
Your preference?
Yeah. And hopefully, because Webster Street has been closed.
Yeah.
And the last thing we were told was that it was gonna be closed another year.
There,
They
yes.
said today, maybe only 6 months. So that would be good.
So can we vote?
Yeah, with these
Call the
additions. Well, what about, did Tammy hear this and did Jill hear this?
As long as we have the quorum, Tammy was coming back to.
She's
make
back.
quorum.
She's back.
So do we have enough people?
Yes, we do.
They're waving their hands.
So can we vote?
We're saying hi.
So we can vote?
Okay.
Okay, are there any opposed? Any abstain? Any recuse? All in favor? Raise your hand. Just say, if you're online, say yes.
One public.
Yes.
Yes.
Yeah.
Great.
Aye, Captain.
Great, motion passes
With the additions.
with the addition.
stronger.
And we will, so you guys.
February, we be.
Zach will get you in contact with
February.
BBC.
Yeah.
And then we'll see if, 86 says they'll come back in February.
Yeah,
You know,
so we can,
fingers
you
crossed.
give them, when do we meet? Give them a specific date. in terms of when-
February meeting.
When they meet,
it's
you know, so
February.
they can't say,
The third Wednesday.
Short notice.
so you can't say, they can't say short notice.
I think
No, I already gave him a date.
Oh,
I already
okay.
gave him a date.
What is
And
that?
we're happy to come back to that.
And that's
meeting.
It's the 18th, February.
Yes, the 18th.
Right?
Yeah.
It'll be DDC time or no?
Yeah, GDC is also coming back.
Well, hopefully.
So
that's-
we're happy to come back to that.
Holiday or anything?
They will be invited.
February
The 86 Trinity and.
And DDC will be here anyway. And if there's anyone else or anything else we think should be included.
First night of
let us know.
Ramadan, and it's also Ash Wednesday.
Thank you so much.
Hey, we're neighbors. You gotta be, yeah, good neighbor policy, which 86 obviously has never heard of.
No.
You know, the sad thing is that if one of those kids gets hurt, I mean, I don't care if anybody gets hurt, but if the kid gets hurt,
Yeah.
they are gonna be liable for so much money.
The debris that's falling on our terraces can easily fall onto one of the railings, bounce off. I mean, it's just, it's really expensive.
Thank you so much and have a good evening. and we'll look
Thank
forward to
you.
seeing you.
Thank you.
Take care. Revised draft.
Oh, sure, that'd be great.
It's up to you.
Okay, we're gonna move on
So
to
you
number
go,
4.
next Tuesday.
A discussion on the protest buffer for houses of worship.
So for any reason you wanna just talk for 2 minutes at the
Based
beginning,
on what happened in
you
Minnesota?
can come and.
No, based on
Getting of the, get this done, I think by 5:30.
the Eric Adams executive orders being reversed, inclusive of the one that was meant to protect houses of
But
worship.
anything, get it out to the public.
It was written with synagogues in mind, it would apply to all houses of worship. Donnie reinstated it, but his executive order doesn't stipulate a particular number of feet. However, he also instructed Commissioner Tisch to put something in place. Hers calls for a 15-foot buffer zone. Julie Menon, the Speaker of the Council, has proposed 100 feet,
I'm sorry, I missed.
which I personally think is more appropriate. Okay, so the item number 4,
Yeah, buffer of what?
the,
Oh, protest.
yeah, a protest buffer, so that people aren't standing in front of churches, synagogues, and temples, or have you, protesting.
Does that buffer zone allow people to get into the church?
Well, that's why, People shouldn't feel intimidated going to service or coming out of service, by anyone, whatever the kind of protest it is. So we want to keep people away. So Eric Adams had put something in place that began, with synagogues in mind, but then went on to apply to everybody. It was an executive order. So it wasn't like a regular bill that went through the legislature and was passed. So when Mamdani came in, he reversed all of Eric Adams' executive orders with an executive order of his own. And then he went on to do another that, after, pushback about this, that reinstated this, but his doesn't stipulate a particular number of feet that one has to stay away. However, he also instructed Commissioner Tisch, the NYPD, to have her officers enforce people not being in front. But her order, or her, what she did at the NYPD, only calls for 15 feet. Which I personally don't think is enough, and I guess Julie Menon didn't think it was enough, because she's also written a bill that she or hopes to pass through the city council, calling for 100 feet, which I would agree sounds more appropriate. We have 100 feet in place for things like you know, alcohol and elections and,
15 feet is
yeah.
5 yards. Football field.
How they gonna, what are they gonna do to make a buffer zone? How's the buffer zone constructed? Like, is it?
The NYPD would make sure that people aren't beyond the point where they belong. You know,
They usually put up the police
There's
barricades,
barricades.
those gates.
Um,
You see them on-
They only allow people. who
It's
are
not a
coming to
permanent.
the Well, exit. Right, no,
Yeah.
I know.
Oh, the metal gates, like around 26 feet.
But how do they know, so how do they know that this synagogue, this church, this such and such is going to be protesting against?
Right, because they're spontaneous.
Right, they.
Sometimes they know in advance.
Sometimes they know in advance.
Yeah.
When they do, they would put it up in advance. When they don't, police always show up anyway. At
There's
that
usually a lot of
point,
social media.
they're gonna take over the scene and they're gonna say you can only be here. And it's like Diane said, then there's 100 feet in place for elections as well. So if you can't be campaigning or electioneering within 100 feet of a poll site. If you do, that cop that's in there is going to enforce that, or then you can call the police. So it's gonna be the same type of situation.
So this 100 feet or, I mean, I don't, you know, that's fine with me, but the 100 feet buffer zone, what do they do to you if you violate that buffer zone?
They would probably say you have to
arrest
move,
you,
and if
like
you
they
don't
can
go
go,
back. Yeah. And
it would be a
I haven't-
violation or
I
a
haven't read the
misdemeanor.
details, but I don't know that there's, yeah, that
Let's
there's,
still say.
Jill,
Yes, let's just.
Jill saying.
Go ahead, Jill.
I don't necessarily know that there's a physical block put up. I think that just having that regulation, and if it's being violated, I haven't read the rules, so I don't know that somebody in the mosque or in the church or in the synagogue would then notify the police officer, and it would be enforced. But I don't know the details. That would be my guess. And just to be clear, this is to protect all religious prayer from the people who are going to pray from being harassed, whatever their
From any
beliefs.
kind of protest, it's like the Westboro people that would show up at a funeral and, we want to prevent that sort of thing.
But in this legislation, there's nothing that says what happens to these people. What's the penalty for
Well,
violating?
the idea is that if you're violating the buffer zone, the police can tell you to leave.
They just ask you.
And if you don't leave,
Right.
it's like when people protest and they say, you have to get out of the street. And if you don't get out of the street, they arrest people.
Then they start arresting people.
So,
Penalty too, that's the same thing.
Yeah, that'll be like cracking your head open.
They're not gonna shoot people.
Yeah.
yeah.
Not today.
We don't know.
Yeah.
Well,
Okay, so
live in a different world.
Legislatively, that is
Are we
not what
voting
it's
on this?
supposed to be doing.
Yeah, I know. So we have,
So there's no draft, but, my suggestion would be to write something calling for support of Julie Mennon's version.
I'm just reading this now.
It says it's introduced, I couldn't find it. Okay. Oh, what's left? Find the legislation. It was introduced yesterday, it looks like, maybe.
Yesterday or the day before, I saw her on the news talking about it.
But if it's just introduced, it doesn't mean.
So this is, let me
No,
be
I'm
clear.
just saying that we support it. We can include something thanking Mamdani for reversing his reversal, right? And reinstating it to an extent, but we would like it expanded. We would like it.
So this is to be,
Right, we can do whatever you guys want.
I just want to be clear. This is if you are protesting and you are in proximity of a house of worship, not necessarily if you are protesting that house of worship. Am I correct?
I think, yes, that's what it should be.
I'm not
Now-
sure. I think your protest, and once again, we're guessing here, but that your protest has to be aimed at the congregants.
No, I think you shouldn't be protesting at all in front of a house of worship.
But that's what I'm
And
saying.
that's my interpretation.
It
Why would
could,
you protest
I'm
in
saying,
front of the
it
house?
could
We
be,
need to read,
it
we
could
need
be
to read
either.
rules. We're guessing. I think we should read it.
fine.
Because
Because, I mean, I can't see any other
Dad,
reason
can
to be
you pull it
standing in
up?
front of a house of worship unless you're protesting that house of worship.
Well, yes.
You could be in a prime spot that offers a good level of exposure, and it could happen to be near.
I think you're
Like
still.
St.
considered
John's
to be-
Cathedral, you could be
People need
protesting
to
on Fifth
feel
Avenue.
comfortable walking into church.
No, I agree, I understand
So I
that,
don't,
but I
it
am,
matters what you're protesting, nothing in front of a house of worship.
but I am
Yeah.
also saying that you could be in a spot that is prime for good exposure,
It could be.
and that could happen to
It
be
could be.
near a house of worship.
But let's
People
assume-
should be comfortable going in and out of their house of worship, but I am saying that a good place to protest could happen to be.
And let's assume.
I don't disagree, I'm just saying, I think that they would need to find an equally, good spot across the street.
Hey, Zach, can you pull up
Across the
Julie's
street could be 100 feet.
Right, right.
Can somebody? Sorry.
As long as you're walking into or out of a house of worship and there's somebody in their face that's intimidating them when they're going to pray. That's what, yeah.
So it could be
It's about
either or, it could be someone is protesting something,
Yeah.
or it could be someone is protesting some religious group. This should protect either scenario.
Yeah, and if Zach can please pull up the what we're talking about, so we could actually know what we're
He's
talking
looking for Julie Minnen's version.
So here's a thought, the bill has not,
To be clear, no one should be protesting
the
anybody's religious.
bill has not been introduced in the council. It looks like she's trying to introduce it this month. Do you
Oh,
want
it's
to
not out yet.
let it come out and then vote on it once it's out? Cause then you'll have something to look at and you're voting for.
Oh,
it.
yeah. Why jump the
You'll
gun?
be voting for
Yeah.
bill number, XYZ.
Why jump the
Yeah.
gun? This is not
Devil's in
yet,
the
so.
details.
Yeah.
We're prepared.
She's the
I
speaker.
mean,
So as soon
Should be
as
we
it
brought it
happens,
now because of the recent incident
it
where
did
it happened,
Wait,
right?
what was this?
In
Oh,
Queens.
Queens.
It did happen.
What, yeah, I'm not familiar.
There were people protesting Israel and the sale of land in Palestine.
Right.
That they were doing it right in front of a synagogue. And the reason for being in front of that synagogue is because there was an allegation that people in the synagogue, members, were part of or involved in the sale of this land.
So
That was going
you
to
say
inside the
something like,
synagogue,
based
but
yeah.
in anticipation, in anticipation of the forthcoming, of, whatever.
Or we could just wait until it's out.
Yeah, I mean,
Yeah.
if we do in anticipation, we've already done it, and we don't have to do anything. when it
Except
comes out.
work and it's for next Tuesday and it's today, it's Wednesday.
Oh,
I
okay.
think we already have two resolutions we gotta deal with for next Tuesday.
Well, can we vote on,
Can
make a motion?
Can I make a motion?
Oh, Tammy.
I make a motion to table the topic until after the potential legislation for city council at least hits committee or is revealed, so we can have something to look at that could potentially become law in New York City. Right now, we are as protected as we were 6 months ago. There's no difference. We're just waiting for state and local for law. So I have a motion to table the topic.
Tabling it or not?
Yeah, we gotta vote on the motion.
Let's vote on table.
Yeah, that's a motion.
Tammy, wait, I want to say something.
Wait, Jill.
I do think there is, saying something now could help to push it through.
We don't know what it is.
But-
Jill,
but we do-
like, we got
but-
that kind of power.
We should
I mean,
be
it's a
able
good
to
point,
at some
but-
point take a look and know whether Julie Mena's legislation says 60 feet, 100 feet, 200 feet, and what it says to make sure it's broad enough to cover anybody in whatever religion they are. It's not.
Also, but I think we have two resolutions from tonight.
Yeah, I saw how they do. That's what she's got.
All right, I can live with it. I can live with it.
And Jill, I think your point is well taken, other than that fact that she's now the speaker. When the speaker announces something, it gets introduced.
When the speaker
Yeah.
speaks,
Okay.
the spoken listen, the spoken to listen.
The people listen.
So do we have a vote to table? Everybody in
Well,
favor?
I,
In favor
call
of
it-
table?
Yeah.
Table.
Yes.
Table.
Okay, so
Table.
that is table.
I'm good.
So now we need to go back to the first one.
Now we need to go back to the first one, yeah.
Also, you have,
The salt.
Anthony, you have Anthony as a public,
I don't have the salt
public
one in
person
front of
who
me.
wants to say something.
Oh, we have
The
a public
breaking up.
person.
Oh, sorry,
Oh,
Senior advocate leadership team.
somebody.
I didn't see your hand, Anthony Hannigan.
I don't,
Oh,
I don't have.
sorry.
Hi, how are you?
Good, how are you?
Good. So I just had a really quickly, I had brought it up in the big community board meeting last month. If you remember, there was a proposed safe haven shelter at 320 Pearl Street that basically the community strongly opposed. We did win our court case, which basically ruled that the city did not do an adequate fair share analysis. They did not take into account the school into their analysis, and therefore the judge said they cannot move forward with the shelter without a new fair share analysis being done. So everyone has sort of viewed this as a win, but I do know for a fact that Breaking Ground and Slate Property Group, the two parties involved, are currently lobbying with Mamdani's current administration to redo the fair share analysis. If they do a new fair share analysis where they state that the school has been taken into account and they believe it will be safe, they would therefore be in compliance with the court ruling and able to move forward. So we have come really far in this, and the community has really stood together, and we raised a lot of money, and it's sort of unprecedented how successful we've been so far. I just think it would be a shame to drop the ball and allow Breaking Ground and Slate to make another run at this, basically lobbying to Mamdani's administration without the other side getting their say. So I'm hoping that Community Board 1 would write a letter to Mamdani's administration, just reiterating your position, stating that you hope that the administration will honor the court's ruling, and that the administration would work with CB1 on the uses of that site and not use it as a safe haven.
Okay, sounds like something to put on the
Tammy?
agenda so we can do.
She can decide if you want to write one.
Actually, that
Thank you
sounds,
for.
thanks for bringing it up, Anthony. It sounds to me like a
bringing it up.
huge topic that our council member, all of our electeds would do as a letter and we'd be happy to sign on. So I think that
To put it on the agenda.
let's ask council member Marte and see if we can sign on to the letter from him.
But is,
Okay.
has the process already started?
Probably not, because the city has to, but if Anthony doesn't know, it's incumbent upon our electeds to find that out. Because they're sure as heck not telling me.
They won't tell anyone until they actually announce it and do it again. They were not going to publicize that the fair share analysis is being redone.
Correct.
It'll
In anticipation of.
So I have to reach out to, Marte's office.
And yeah, let's put that right back on Zach. Boom. Thank you.
All right, so we're going back to Anthony.
Thank you very much.
Item number 1
Thank you, Anthony, for your diligence.
and the SALT presentation on the Health Act.
Okay, so I just want to say that we're already kind of we're kind of not in agreement about issues about the salt.
Telehealth.
No, that's the Bellevue.
That's
I'm sorry.
No, the salt, the very first with Assembly member.
I don't think we have the res.
Got
Right, I thought we had a resolution here too. I told them that we printed it out. It's not printed here.
No, we don't have.
But
I forwarded
we
it
need
to
to
you.
decide
We
whether we're,
updated version earlier today and I forwarded it to
but
you.
do we want to?
So I was thinking, I'm with
have it.
you.
I'll be in a moment.
Sorry about
I was thinking we could have them come back in March.
Please.
And at that time, I could invite
The
Dr.
people.
Riveman and maybe Kimberly.
And what about the physicians for national health, whatever that group, physicians for
Is it
national
time
health
sensitive?
care?
Well, to an extent, yeah, because their concern is in March, a lot of Americans are gonna lose their health care.
So maybe we
Oh.
So maybe we should do something now? I mean, I don't
Okay, but
know.
here's my question.
What's going on?
March, no, the March thing is the Bellevue stuff.
No, the March thing is the federal thing.
It
the-
affects both.
But-
Oh.
the federal cuts It's going to affect in March.
Okay, well, my question is, even if we wrote something tonight, does that have anything, does that impact what's gonna, happen?
It's just another community board signing on that they can bring to whoever they have to bring it to try to push it through and get it.
Okay, so far they said 3 agree.
Yeah.
That's the only community board?
And
that
one in the
agreed?
Bronx agreed, community board.
So only 2 community boards?
I mean, I don't know, those are the 2 I know of.
What about 2?
Can we get a little more research on it?
Yeah.
And have, I mean, we can ask at the full board meeting, the governor's rep is coming. So why don't we send him some questions in advance so he can talk about it, right? And the public session is about the new budget. So let's ask the questions that we need to ask.
I mean, I would say the governor's probably not for it, and the legislature, Dick Offord has been chair of the health committee in assembly for, he's retired now, but he was for probably 2 decades. And, he wasn't able to get it, through. So there's definitely a lot of opposition.
Well, the insurance.
It's full change in, a health system. It's a very dramatic change
And
that.
people like to have like a shelter, like a protection, like if I don't like this, I want to be able to go there.
A lot of
And
the,
so without an option to be able to do your own thing, I don't see everybody's.
a lot of the opposition has been because by the, as you said, the public employee union, they say we can do better by negotiating our own contract. And
There's
They
definitely
don't want,
various
they don't want to sign on to it.
opposition.
And the insurance.
Just the
That's why
idea,
they feel like they got
that's the
political.
question,
they
but
got
just the
political-
idea of another entity, deciding this is the way things are gonna be, is viewed as anti-union, this period, because you're denying them rights to operate.
But the thing is with the year, it's like every year things keep changing and now, I mean, even people without union insurance, every year, like there's been changes to, I'm not on the retiree plan yet, but there's been changes to my coverage and.
It's not what you picked or what you paid into.
Well, it's not, I mean, and I know people who are on Medicare and there've been changes to Aetna and they're kicked off the insurance and they have to scramble for a new insurance. So every year you have to, and then changes to prescriptions and formularies. And, there's a lot of uncertainty with each year.
What's gonna give us?
I think it sounded good outside of those things. I mean, that's why I asked those questions. I was like, wait a minute. I know my constituents in my neighborhood, they're gonna be like, no, my union, my private thing, this. And I had the thought also.
And they're also pushing people toward this advantage plan and.
But doesn't, like he said, doesn't necessarily apply so much to Community Board 1. I think most people in Community Board 1 are either insured or they've got the money to pay the doctor and that's the end of
But
it.
on the other hand, a lot of people are
Not all.
paying more and more,
You said,
more and more for their insurance and getting less and less coverage. So the
Yes.
idea is
But I
that you're
think
getting bigger,
Community
bigger
Board
deductibles and,
Yeah.
and you basically have insurance that doesn't pay for anything.
I had the thought also, I mean, I didn't bring it up, but like during COVID, my mother went into Hebrew Home. A lot of people want to get their parents into Hebrew Home. They were like, oh.
I'm very familiar.
Yeah. And I'm thinking like, okay, long-term care, but long-term care to what extent? Like what kind of quality?
Right.
Because there's all kind of places, but I was able to get my mother into like it still wasn't wonderful because it was COVID, right? But it was still like the better place of.
Bad places was.
Right, COVID and bad places was even worse, exactly.
But then
So-
also long-term care,
But-
which doesn't.
But it's gonna be like this equal thing that could be great.
Or not. Well,
Or it could be not, right?
Let's think about, and I'm not using it as a bad word, socialism, all right?
Mhm.
So everybody's supposed to get the same thing, but I think we brought up some of the issues that if you now have, 10 million people all trying to get to see their doctors, get their coverage, and the graying of America, which many of us are involved in.
The gray.
Now, wellness need having home care, we all need to go in a facility.
Oh, Lord.
It's going to make it's like England or any place else that has socialized medicine, there are long waits.
But
to
what
get
good,
to
what good
doctors.
is less of a weight if you can't pay for it?
Also, I had an experience, after 9/11, I had Medicaid, but I was pregnant, 9/11. So they gave me the Medicaid and food stamps when I went down to the Department of Health or whatever, they were handing out stuff. So I took my kids to the dentist right here on Chambers Street. So it wasn't like I went into, you know, a lower income neighborhood or whatever. Right here on Broadway and Chambers, I took my kids to the dentist. They had people waiting forever. So when I went back to work after 9/11, now I'm taking my kids there because they're being treated, they're putting caps on my daughter's teeth and all this stuff, and I have other insurance, and they still having me wait there. And I realized, like, no, like you're treating everybody like they have Medicaid. I have to go back to work. Like I'm bringing my daughter to the dentist, and then I gotta go back to work. I don't have time to sit here all day with you.
With the same insurance or with work insurance now?
It was with my work insurance, but they were treating me the same. I guess we were in the system, and I was like, I can't have this. Like,
But that's what
I'm
I'm
gonna
saying.
have private insurance because I have a job, and I gotta get back there. You know, I can't sit it all.
What is it? Everybody has the same
Pediatric
choice.
clinic
Yeah.
Downtown that takes insurance. Good luck.
No, but what I'm saying is that everybody has the same insurance. I mean, I'm not saying it's necessarily a bad thing, but I think people have to be aware that there may be longer waits. And we're already now waiting 4 months to see a specialist. You know, Tammy, you have anything to add?
Yeah, I literally have an appointment next year with somebody that works with memory.
No, I waited
Don't
a
forget
year
it.
for my ENT.
That's kind of ironic, don't you think?
Yes.
We don't have enough doctors. Yeah.
Yeah.
They remind you.
I have to say this, I waited a year for my ENT, but when I saw him, I got the exam of life.
Yeah.
You know, I mean,
So it's
he did everything.
always.
I know,
Yeah.
yeah.
Might need to-
Y'all mind if we're not gonna pass a reso, can we go to the one we are gonna pass?
No, he did.
Is it,
So now we only have one.
is it, like two, because there's the Bellevue and the, Trinity thing. Or do we have?
Trinity.
We have Trinity.
Yeah.
Okay, no.
We passed. We didn't vote on Bellevue. We're gonna vote on that.
Okay.
Okay.
All right, so let's go about,
Let's vote on
so we're leaving, we're gonna.
But when we think about having them come back in May with some other experts,
May?
or not May, March, I'm sorry.
I think that's.
Is that gonna be, well, we were discussing the time, is
Yeah.
it gonna be?
Or should we do something now small?
Okay, but see, my question I asked you is, even if we were to pass something, how does that affect the vote in March? Does it really do it?
I mean, it's a statewide issue, so one
Yeah.
community board is not really gonna.
There's only 2 community boards that have said anything about it that we know.
Well, can we put a soft resolution, you know, like just in, you know, based on the information
But
we
we
have?
can't even agree.
That's, I was gonna say the same thing, like, if we agree to the general concept,
Yeah.
depending on the,
Yeah.
you know, of course,
I would-
the details.
I would agree with that.
I mean, like
Well,
a generally supportive, but
Yeah.
Are we all supportive?
You're a lawyer, Morton, and you have language for us to say we kind of generally support it.
I
We have to make the time.
Okay, Jill and Tammy, are you supportive of this?
of a general kind of support, you know.
Are we in support of?
That's
That's what I'm asking.
yeah,
We support the principles behind the,
But that's what I'm asking. Are we all in support?
can we take a poll now? Who's in support? In general.
We have questions, so how can we be in support of?
Based on what I heard now, generally in support, I do need more information,
Yeah.
but based on what I know now,
Yeah.
we're
I'm
concerned.
in support of the information I have
In support
at
of the
this,
concept.
Yeah.
at this point.
Okay.
If in February it's something else, I may not be in
So
support.
is everyone in this room in support of what you've heard now?
It's based on what I.
Jill, are you?
Yeah.
Right, hold on, guys. Tammy and Jill, are you in support of enough for us to go forward with writing a soft resolution?
Do we have to mention telehealth?
Different resolution.
There's a
Different resolution.
Oh, sorry.
Oh,
Yeah.
the first one. We didn't get there yet, Jill.
Oh,
This is the one
speed
for
up,
the
speed up.
universal
I'm
health
already
care.
on telehealth. Oh, okay.
I thought telehealth was part of that original resolution that they asked us for.
No, this is not that, no.
Telehealth is Bellevue.
Oh, we're talking about supporting
First one.
the statewide.
I'm gonna abstain. I don't feel like I have enough information. Sorry.
Look, I support the concept. I'm happy to do a soft support for it. If there's a bill coming out in February, is that what we're saying?
But why wouldn't Melanie said that we could submit all the questions to her and she'd get us answers. So why aren't we spending the next 2 weeks getting questions together of all the concerns that people have, right? And asking perspectives and then passing one in February.
And I suggest that the members that are not in attendance, that they go back and listen to that Zach sent out an email requesting that they listen to this meeting and submit questions.
Yeah, absolutely.
So, but you think that if we did that, we'd be ready in February? Because February, we have construction and
We have a
other
big
things.
meeting in February.
So if we're not ready to do it then, I think it should be March.
You can give it a shot for February. I mean, it's a big topic.
Yes, because March, the
Well, so
HR, whatever, the big, beautiful.
Okay. At this point, what we're hearing is that we're gonna send out questions. And Zach, it's okay that you contact the board members committee members that are not here and ask them to listen to the YouTube meeting and submit questions about the SALT Act? Okay, great.
And can I just make a general suggestion that we really need to read the bills in their entirety before we do a reso ever? Because we don't know what it says.
Pat, SALT is the.
Yeah.
It's called the New York Health Act.
Yeah, so we need to read the act, whatever it is, we need to read it. Even before we ask our questions.
So let's move on to the Bellevue.
All right, so yes. Bellevue, I think we should present 1, 2, and 3 at the full board, that like we support it and let the other members.
We can.
Yeah, I'm nodding down.
Okay.
Because I mean, I disagree with you and Jill and
I do
Tammy,
too.
that I think that.
So I think we should present the whole resolution, and if the other, 30 members feel like, no, we agree that that should be cut out, then we separate it.
Okay, how do we feel about that?
I'm, Tammy, Jill,
Okay with that.
I'm good with that.
Tammy?
Okay, so we're gonna rock and roll? So you're,
Okay,
are
so,
we writing a reso?
Yes.
To all three?
yes, give us the resume.
Okay, good. Where is it?
Bellevue.
Okay, so can we send this out to the board members that are not here?
We have a forum.
We have a quorum right now.
So anybody opposed to supporting the Bellevue reso, the Health and Hospitals Corporation reso?
Okay, so rock.
Anybody abstaining?
Didn't Tammy say she was abstaining?
I think she's abstaining from the salt.
Oh, wait, Tammy's hand is up, or, I don't know, she's waving.
I'm abstaining until I read it a little bit more carefully. And you've taken it.
Still abstaining.
I feel like we don't have the full story too, if that's what you're saying. I am concerned about
For Health and
cost.
Hospitals Corporation. Okay, any recusals?
So Tammy,
No.
Jill,
Okay.
and everybody else.
2 abstentions, Tammy and Jill.
So it's a theoretic.
Okay, resolution passes.
Motion to adjourn.
Anybody want to bring up anything else? Anything for next month? Next month, we're having DDC. Mark, you wanted
Did
to
you
launch
launch Scott?
What was?
Oh, for GDC, I think that's what we said.
No, I think now we're
Show all.
because we haven't done everybody in a couple of months, right? But, yeah.
And first precinct, or no? When we have them?
Here's the.
Or if there's anything to have on the file.
Oh, thank you.
Hey,
Oh,
guys,
The Health Act, yes.
in preparation for next month, when we're doing construction, there's a really cool, really good social media post on the intersection of the construction about the spaghetti below ground, and it was in our district, so I thought maybe I'd share it out for everybody. I think Zach, I sent it to you.
Did you?
There's a couple videos, yeah, on the wires.
Oh.
Yeah.
Okay, yeah, I that what it was? I just took those.
Here's,
Wait, I want to make an not important announcement. I actually attended. I attended this meeting last week, but you weren't holding it. I actually arrived at 5 o'clock. I had the dates mixed up on my calendar.
Wait a minute, I missed that. She came last week at 5.
Yeah.
I'm gonna make you a monthly appointment too.
And I just
Yeah.
walk through the